Royal Commission is now in session.
Yes, Mr Gray.
Thank you, Commissioners. I wish to mention a matter concerning management of the exhibits from yesterday's hearing. Specifically, it relates to the bundle of statistical graphs and information referred to by Ms Boland and Ms York, RCD.9999.0004.001. That document is currently part of Exhibit 1-6, Ms Boland's statement and annexures. However, because that document was partially verified by Ms Boland and partially verified also by Ms York, I wish to excise it from Exhibit 1-6 and tender it separately as the next exhibit in the hearing.
Yes, well, if it's convenient to do that now, we can do it now, or if you'd prefer to do it at another time, that's also a matter for you.
Thank you, Commissioners. I seek to tender that now, RCD.9999.0004.001, which I believe would be the next exhibit number 1-13, I believe.
Yes, very well. The document entitled Projected Population Aged 65 Years and Over Australia, bearing the code number that you've just read out, will be Exhibit 1-13.
Thank you.
Yes, Ms Bergen.
I call Associate Professor Edward Strivens.
I solemnly and sincerely
declare and affirm
that the evidence I shall give
will be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Associate, please bring up document number WIT.0021.0001.001.001. Associate Professor Strivens, is this your statement?
It is.
There should be a hard copy in the witness box in front of you. Do you wish to make any amendments to the statement?
No, I'm happy as it stands.
And are its contents true and correct to the best of your knowledge and belief?
To the best of my knowledge and belief, yes.
I tender the statement of Associate Professor Edward Strivens, document number WIT.0021.0001.001.001.
Is the witness statement of Associate Professor Edward Strivens, dated the 28th of January 2019, will be Exhibit 1-14.
Associate Professor Strivens, could you please summarise your professional background and qualifications?
Yes, I'm a geriatrician, so that's a fellow of the Royal Australasian College of Physicians, and I'm currently president of the Australia and New Zealand Society for Geriatric Medicine. So we're the peak body for geriatricians and trainees in geriatric medicine within Australia and New Zealand, with around 1,200 members across Australia and New Zealand. Clinically, as I said, I'm a geriatrician based in Far North Queensland, and I cover both inpatients and outpatients, and also domiciliary care and the care of older people within residential care facilities. I've worked in Far North Queensland for around 20 years and have been a specialist in geriatric medicine for around 15 years. My clinical interests and specialty is around the care of complex older Australians, around geriatric evaluation and management units, dementia and delirium care, as well as models of integrated care and primary care models of geriatric medicine as well.
Okay. Now, what is the main reason that older people move into aged care facilities from the perspective of a geriatrician?
From the perspective of a geriatrician, I think it's important to realise that often the trigger for entry to either complex coordinated care or residential care is often a physiological or medical one. Although we know that there are complex psychosocial situations that may result in people needing to enter residential care, the majority of the times it's actually due to an acute or subacute medical event. So this might be progressive cognitive decline, it might be an acute event like a stroke, or it might be more progressive chronic disease. But in the majority of cases, there is medical comorbidity contributing to that admission.
And perhaps in contrast, what's your experience of the triggers for applications for home care packages by people as they age?
And this is an interesting question, because often we hear that for also a single service, such as, say, Meals on Wheels or home care, that this is often a purely social reason for receiving care. But some of the work we did even 2 decades ago now, looking at the old home and community care program up in far north Queensland, found that actually people who were referred just for home care, over half of them in the next 12 months had a hospital admission. And this really indicates, I think, that we often see that there are that these presentations for requests for services are often sentinel events, and a time in someone's care where you can actually intervene, both diagnostically and through management techniques as well.
How do geriatricians work with other professionals in the care of people as they age?
Geriatricians as medical specialists work very closely with an expanded interdisciplinary team. I think it's important to realise that geriatricians, if you like, play very well with others. We work well with primary care, with general practitioners, but also the whole extended interdisciplinary team. So here we're talking about trained nursing staff, allied health professionals, be that physios, occupational therapists, dietitians, social workers and speech pathologists, as well as pharmacists, psychologists and other experts in the mental health care of older Australians as well. I guess our role as geriatricians is often in the diagnostic side of things, but also in the team coordination as well, and providing that coordinated care for older Australians, especially those with complex medical comorbidities and increased frailty.
Associate, could you please turn to document number ESG.9999.0001.002? I want to ask you about comprehensive geriatric assessments, and what does a comprehensive geriatric assessment cover?
Well, as you can see, we defined in our position statement here that comprehensive geriatric assessment is a multidimensional, usually interdisciplinary diagnostic process used to quantify an older individual's medical, psychosocial and functional capabilities. So it's a diagnostic process. In a lot of ways, it's analogous to a surgeon's scalpel or a gastroenterologist's endoscope. It's our diagnostic and therapeutic tool to look at intervening to find the causes of functional decline in older people, but also to look at strategies to remedy them as well.
And what are the guiding principles that are applied in comprehensive geriatric assessments?
Well, the guiding principles is really, first of all, this is person-centred. So the assessment process really has to be central to an older person's needs as well as their wishes. It's something that's shouldn't be applied indiscriminately, but used with precision. It needs to be multidimensional. So when we talk about multidimensional assessment, what we're looking at is medications, we're looking at medical causes, we're looking at the social situations, we're looking at functional deficits, we're also looking at cognition, physical examination, and then using this and tying this all together to come up with a series of recommendations. As I said, it should be targeted and it should be interdisciplinary. And when we talk about interdisciplinary care, that's using the different disciplines together to come towards a common plan of action rather than multiple agents working independently. So it's not just the people involved, it's actually tying together those people as well.
Operator, could you turn to page ESG.9999.002? 0007. Here on the screen, I've asked the operator to pull up the Australian and New Zealand Society for Geriatric Medicine Physician Statement number 8, Comprehensive Geriatric Assessment and Community Practice. I'd ask you, Associate Professor Strivens, to sort of further describe the domains that are covered in a functional assessment of a person.
When we talk about functional assessment, we often separate things out according to the personal activities of daily living, which really are referring to things like mobility. They're referring to walking, referring to bathing and grooming, dressing and toileting, incontinence and feeding. So they're those basic activities which we do on a day-to-day basis. Instrumental activities of daily living are, I guess, a slightly higher order functional assessment. So this is looking at us interacting with our environment as well. Things like being able to prepare a meal for ourselves, being able to look at doing our own shopping, being able to manage our own medications, our transport and our finance. And it's important to realise when you're looking at functional assessments, this is not a binary system. It's not something you can either do or you can't do. There's often gradations within it, and this is where some of the finesse of assessment comes in. It's not like one day you can manage to cook and the next day you can't. It's often that you see changes that occur where maybe the repertoire of cooking is reduced, maybe that people overseason and underseason become more reliant on recipes, and these can be indicative of cognitive or functional decline prior to the loss of those skills. So again, it's you'll often find that, for example, with cognitive impairment and dementia, people will lose those instrumental activities of daily living before they lose personal care activities.
Okay. Following a comprehensive geriatric assessment, what clinical conditions and interventions might a care plan provide for?
So the care plans that we might produce at that point will be around looking at multiple interventions. So those, I'll take for example maybe a person that presents for a comprehensive assessment following fall. What we'd look at then would be the medical reasons for their falls. Are they, for example, do they have vision impairment? Are they on a number of medications that might drop their blood pressure and make them faint and more likely to fall over? But also look at that interactions with their social and functional abilities as well. So is it to do with the fact that they have poor lighting at home? Is it to do with scatter rugs? Is it to do with the fact that they actually have reversible causes of disability? Do they have cataracts, for example? Do they need corrective lenses? Do they actually need to look at an occupational therapist visiting them at home to minimise their risk of falls as well? So what you'd come up with is a person-centred, multi-dimensional series of recommendations that would start with the most urgent and pressing and go through all those examples of where you may intervene. And that's what's key here is the intervention before irreversible disability. And I think we too often look at an assessment coming out with a recommendation for a service. So, somebody is falling, so therefore you look at them needing to go into residential care, whereas actually what we're suggesting and what is well published and well researched is that a comprehensive geriatric assessment coordinated with the geriatrician can actually have an impact before that need for supportive care to actually look at treating those reversible causes of disability. What you treat, what you can't treat, you ameliorate.
So here when you're talking about early intervention, is that while the person's still, for example, living at home?
It's still example living at home, but also looking at presentations within residential care. So again, it's not that someone is static with their functional decline, and there are opportunities to intervene at sentinel points during a person's journey through residential care as well, looking at falls prevention, looking at cognition, looking at medications as well.
Turning to the topic of medication and psychotropic prescription, what role do geriatricians have in monitoring appropriate use of medication in people as they age?
Yeah, well, medication and medication review is a key component of a comprehensive geriatric assessment, and we look at the number of different medications they're on, and I'm talking specifically, I guess, about psychotropic medications. So these are agents such as antipsychotics, but also including other sedatives and other antidepressants, all of which have a central action. Geriatricians, as I said before, work very well as part of that interdisciplinary team, and that review of medications would also involve primarily general practitioners and primary care physicians, as well as community pharmacists as well, and nursing and other allied health staff. But geriatricians carry with them some expertise to look at both the impact of the medication on the person and the impact of the person on the medication as well.
Okay, so when you talk about the impact of the medication on a person, does that include monitoring their oral health and dental hygiene?
Yeah, it's a good question about dental hygiene and oral health in older people, and it's something, of course, I would again defer to dentists and dental health specialists who have a far greater in-depth knowledge of the technical aspects of dental care. But I would comment around the fact that poor dental health impacts significantly on people's wellness generally, their quality of life, their ability to swallow certain medications, and also if we look at, say, for example, drugs that are used to treat osteoporosis or thin bones, poor dental health means you can't use these agents because of the risk of a rare but incredibly significant side effect called osteonecrosis of the jaw. So poor dental health removes one of the interventions that we have that can prevent people from breaking their hips, which is often a very serious consequence of a fall. We also know that the cumulative inflammation that can be caused by chronic dental ill health is also bad for you in many other ways, including to your cardiovascular system, and also as a portal for infection. It increases the risk of, if you have a poor swallow, for example, of aspiration events and bad bacterial infections affecting the lungs.
So would you say this emphasises the importance of an integrated approach to the medical care of people as they age?
Yeah, and I think that too often we sort of exclude dental health as being an absolute vital part of that extended interdisciplinary team, and access to that is key wherever you are, be that in the community, but even more so within residential care.
So continuing on the topic of appropriate use of medication, how are psychotropic medications used to manage people with dementia?
Look, and I think this is an area of key interest to all of us working within the field. I think we've seen occasions where psychotropics are used inappropriately, and we know that although it's part of what can be used, I think when we're talking about behavioural and psychological symptoms of dementia, it's important to realise that these are often, I guess, an expression of unmet need and actually indicative more of cognitive disability rather than necessarily psychosis. So if you're looking at psychotropic medications, there is sometimes a role for them, but to use an example that I did refer to in my evidence, if we treated 1,000 people for a few months with antipsychotic medications, we would get some improvements, for want of a better term, in some of those target symptoms in around 10%, maybe 12% of those people. However, we would see an excess of 10 extra deaths in those 1,000 people and 16 strokes, as well as around 10 to 12% of people taking those medication more likely to fall over. So they do work, for want of a better term. However, the side effects will often outweigh the possible benefits. They are a last resort, but too often we see them used as a first resort. And the use of medication should never be a substitute for good quality care, and non-pharmacological management strategies are always and should always be the first step, and we shouldn't be using strong medications as a substitute for care.
So what proportion of use of psychotropic medications to manage people with dementia is appropriate in your view?
Well, I mean, I guess the figures speak for themselves in terms of how much they're used at the moment. We see probably about 80% of people in residential care with dementia on one form of psychotropic. And remember, this isn't just antipsychotics, this is antidepressants, this is sedatives as well. And around 10% of those might benefit. So if you're looking at, for example, that I'd commend the Commission to look at some of the work of Professor Henry Brodati, and the Brodati's pyramid of looking at interventions with BPSDs, behavioural or psychological symptoms of dementia, and really those severe symptoms really are seen in sort of 1 to 10% rather than 80% of people. So we don't have a precise figure, but you know, if you're looking for a ballpark figure, it would be on the lower side rather than the higher side of that.
And so by biological consequence, what proportion of use of psychotropic medication is inappropriate? Is that the balance that you're talking about?
Yeah, and that's the balance there, is that when all you have is a hammer, every problem looks like a nail. And I think this is one of the issues with antipsychotics, is it far too often becomes the first step to look at, say, managing somebody who's presenting with agitation, sometimes some physical outbursts, rather than actually looking at the reasons behind this. And when we're looking at these conditions more as a cognitive disability, this can be actually due to the physical changes that happen within the brain. Agnosia, for example, or the inability to recognise people or objects for what they are, can actually lead to a significant amount of distress. And there are non-drug strategies that can reduce this. The same with, you know, the looking at a whole person's life story and why they're presenting like this. You know, for example, I work up in the far north. We've got a lot of old bushies up there who are used to getting up very early in the morning. I saw a gentleman not that long ago who was a baker, and he was used to getting up at 2 o'clock every morning. He would continue to get up at 2 o'clock in the morning, but within the setting of his residential care facility, that was a potential problem to the facility. It wasn't necessarily a problem to him.
So what are some other risks of the inappropriate use of psychotropic medication?
Well, as well as I sort of pointed out before about the risk of death, there's also the risk of permanent disability in terms of increasing stroke risk, also of increasing postural instability and risk of falls. We also see that there's studies that even show that risk of pneumonia increased within the first 2 weeks of treatment with an antipsychotic because of that sedation effect as well. But as I said, I wouldn't like to say that they're never appropriate, because they are in that small proportion of people, probably around the 10% of people who would benefit. And this may rise according to other conditions. And of course, it would vary according to the patient mix. It may look different, for example, in somewhere with a high proportion of people with cognitive impairment within the facility or within the hospital or community setting.
So what can be done better in this regard?
I think there's a case here for medication stewardship. We hear talk about how we manage antibiotics and some of the good work that's done within hospitals in terms of antimicrobial stewardship. I think there is a role here for antipsychotic stewardship as well. We know that there are both, I guess, levers in terms of looking at indications throughout the PBS, and the use of medications off-label as well, and the use of medications at varying doses. The principles of I guess, aged care pharmacotherapy are around the start low, go slow, and review regularly. So it is about, if you have to use an agent, it's about using the smallest possible dose for the briefest possible time and making sure it works. And if it doesn't work, you don't just keep on increasing or adding different agents. You look at withdrawing and trying other things. And again, I'd emphasise that non-drug treatments should always be tried first. And this is often more time-consuming and more labour-intensive, but it's what we need to do.
Operator, could I ask you to turn to ESG 9999.0003.0002? Now, before I ask you some questions about position statement 29, prescribing in older people, Commissioners, I need to tender the exhibits together with the statement, if the exhibits to Associate Professor Striven's statement
I think,
could be included in Exhibit 1.14.
Is this document referred to in the statement?
Yes.
Well,
Commissioner.
in that event, I'll simply indicate that the Exhibit 1-14 includes both the statement and the attachments to it.
Thank you, Commissioner. Now, I want to ask you about psychotropic medication. I want to ask you about pharmacokinetic and pharmacodynamic changes that occur with normal ageing. But before I do that, could I ask you to explain those terms, please?
Essentially, what the terms mean is what the drug does to the body and how the body responds differently to the drug. So, when we're talking about these changes that medications have in the elderly, we're looking at both changes in the older person's body that actually impact on how drugs are metabolized, which might be, for example, changes in kidney function, changes in liver function, changes in the way that the body is made up in terms of the proportion of fat and muscles, which implicate how the drug is distributed throughout the body and how the body processes drugs. So we can't assume that how somebody responds to a drug at 20 is the same as they're going to respond to a drug at 80. And this has particular challenges because of the number of medications that people will be on. I mean, we've had to invent a whole new term of hyperpolypharmacy to catch up with people on 10 or more drugs, because really polypharmacy or 5 or more drugs wasn't actually cutting the mustard in terms of differentiation, because so many people are on so many medications. And this becomes one of the issues with working with clinical guidelines. And I'd come back to, again, I guess, some of what we do as geriatricians, whereas single organ specialists like a cardiologist or a respiratory physician will be looking at particularly the impact of these medications on heart health, but it might have a contrary effect on brain health. So it's actually tying together the risks and benefits of both individual agents and multiple agents together. And many drug trials are actually done on younger Australians or younger people throughout the world. Very few drug trials are done on people over the age of 75 or 85, which is, you know, the people that we're predominantly seeing within residential care setting. Very few drug trials are done on people with coexisting cognitive impairment. And clinical guidelines will tend to suggest treatment for a single condition rather than looking at multimorbidity, which is what we see in the majority of complex frail older people, especially within residential care, who will have cognitive impairment as well as arthritis, as well as heart disease, who may have had a stroke before and got problems with their bowel and their bladder. So there's multiple medications there, and it's also the idea of a prescribing cascade as well, where we see that a medication is started for a particular condition. And an example I might use, and is referred to in one of the documents, is around the drugs that we use to sometimes treat the symptoms of dementia. These are a class of drug called a cholinesterase inhibitor. That's one of the chemicals which is lost when we see certain types of dementia within the brain. We use a drug to treat that, but one of the side effects of an increased amount of this chemical within the body is that it may cause increased urinary incontinence. So then we start another medication which actually goes contrary to the first medication to decrease the activity of the bladder, which then causes increased confusion because it reduces the level of this chemical within the brain, which then means we add another medication, and before you know it, you've got half a dozen different medications, half of which are opposing the effects of the others. So when we're looking at that, we're really trying to evaluate the overall drug burden, if you like. We're looking at opportunities to reduce inappropriate medication, but also to not fail to be able to manage or treat conditions that are remedial or treatable as well.
So what are the implications of frailty, for example, on polypharmacy and drug prescription?
Well, frailty is, I guess, when we're using frailty as a term, frailty is really, I guess, a physiological syndrome characterised by decreased reserve and resistance to stressors. So I guess it's that cumulative decline of lots of little events or a few major events over time that occurs across multiple health systems and multiple physiological systems and increases someone's vulnerability. It's one of those hard things to define. A colleague of mine refers to it a little like art. Frailty is like art. It's hard to define, but you tend to recognise it when you see it. And I think that's very much the case with frailty, is we all know people who are in their 80s who are still contributing and still have an active role in very few medical conditions versus someone in their 70s who's had multiple events. And of course that frailty has an impact on how people respond to medications, and also has an impact on their likelihood of side effects and the impact of those side effects on their everyday life. If you think of frailty as or pre-frailty, if you like, as a threshold, the more reserve you have, the bigger the insult you need to slip into disability. If you have multiple existing comorbidities, then often the insult can be minimal to actually dip into that degree of frailty.
So what are the implications for dosage in terms of medication prescription of frailty?
It's recognition of frailty, it's management of frailty, and it's also in terms of drug prescriptions, it's again the looking at starting low, going slow, and reviewing regularly, and making sure that it's almost an art of choosing the least worst side effect of medications. For example, if a medication if someone's frail and has been losing weight, then the medication you use to treat their depression might be one that encourages weight gain rather than weight loss, and where medications can have equal efficacy but their side effects profile is different, and that involves skill, knowledge, and education.
Just unpicking that a little further, can lower doses of medications achieve a similar result in a frail person? Absolutely.
And if you look at some of the doses of medications that are used in older people, they can be fractional to what you'd use in a 20 or 30-year-old. You'd use lower doses. As I said, start low, go slow in terms of the incremental increases, and you'll find that lower dose will have a very similar therapeutic effect.
So what does that mean for quality, and what quality principles should be applied?
The quality principles there is around making sure that you've got the right dose for the right person, so it's about individualising care, but it's also around the issues of consent. And I guess that's been one of my concerns when we've looked at consent for the use of some of these antipsychotic agents, and that there's a good study from New South Wales to suggest that only 6.5% of people actually on antipsychotics have been adequately consented. So by adequately consented, we're really talking about a discussion on the side effects and benefits. And I think that's the idea of targeting your interventions. I think although we've talked about lower doses having a similar effect, it's important not to look at underdosing as well. And I guess I come to this a little bit in my evidence when we're talking about pain, because there is an issue of undertreatment of pain as well, is that we have to be careful in making sure we get the lowest effective dose. And the second part of that, the effective dose, is important, as well as always combining it with non-drug treatments as well.
So should pain be sort of conceived of differently in the approach to medication management and separated out?
No. Look, I think it's not saying that you wouldn't treat pain at an initial low dose. It's just the importance of up-titrating any medication to get the desired clinical effect, and the desired clinical effect in cooperation and directed by the person that you're treating. So this might be that someone say, I am willing to put up with X side effect to get Y benefit. But that's the idea of informed consent with medications, is to actually talk about risks versus benefit and what risks will you accept to gain what benefit.
How important is consent, and consent from sort of family members? in
Well,
addition to
as I said,
consent from the
that's one of the concerns here. I think is that agents are being used without a full discussion in terms of benefits and side effects, and these discussions with ideally with the person themselves, and if they're unable to consent due to issues with capacity, but even with reduced capacity, I would still be discussing this with the individual, but also with their substitute decision maker.
So what screening tools are available for to assist in the task of prescribing medication?
Yeah, there's a number of screening tools that are appropriate for use in older people. There's I refer to them as the stop-start combination, which is a screening tool for older person's prescription. And this is around looking at what medications might be able to be ceased, and also looking at which conditions are able to be treated and aren't being treated. So I think that's the delicate dynamic here, is we don't want to say you've got to stop all medications because you're going to miss opportunities to positively impact on quality of life and prognosis as well. From an Australian viewpoint, we have the Drug Burden Index, as well as an American tool, the Beers criteria, which again is looking at sequentially what medications you might try and remove.
Operator, if you could turn to ESG.9999.0003.0004. So is this the publication produced by the Australian and New Zealand Society for Geriatric Medicine, and your society's description of each of the tools that you're talking about?
It is.
Now, how effective are these tools?
Look, I think that we know that they are effective and can be used by a combination of geriatricians, pharmacists and primary care physicians, and they can start guiding a conversation. I think, again, it's about guiding that conversation of benefits versus side effects for each of these medications, and guiding prescribers and practitioners as to which medications you'd look at trying to remove first, which are the ones with the highest level of side effects. And again, it's about minimising the overuse as well as the underuse of medications.
Now, turning to the topic of dementia, what is the clinical definition of dementia?
So, dementia is an acquired condition of the brain characterised by multiple cognitive impairment across multiple cognitive domains, and severe enough to cause a decline in social or occupational function, and not better accounted for by delirium or depression or another medical or psychiatric condition. So, breaking that down, I guess one, it's progressive. So it's something that's got worse from point A to point B. It causes deficits in multiple cognitive domains, and by those cognitive domains, the one we think of most commonly is memory, but not all dementia causes an issue with memory, at least in the early stages, and can often impact on other cognitive domains as well, such as speech, such as purposeful movement, such as recognition of people or objects, and also comprehensive planning and executive function. So this is sort of amnestic symptoms, aphasic symptoms, agnostic symptoms, and apraxic symptoms, as well as dysexecutive function. So it's often multiple domains that are affected. So it might be memory, but also someone might have problems remembering names, remembering faces, or getting themselves dressed, or planning. And that executive function is often an early stage, can be an early stage condition where people have problems, say, managing complex financial or some of those high levels instrumental activities. It's progressive over time, So we've seen someone get worse, and as I said, it impacts on that day-to-day life.
What numbers of Australians live with dementia?
Well, at the moment, we've around 400,000 Australians living with dementia, and around 25,000 people under the age of 65 living with dementia as well, who might have what we call young onset dementia. So it's not only a condition of older Australians, although the biggest single risk factor for the development of dementia is increasing age. We know that by the predictions, by the middle of this century, we're likely to see up to 1 million older Australians suffering from dementia, and it's the greatest cause of disability in those over the age of 65 years of age. And now, as some of the evidence that was published yesterday, is also the leading cause of death. It's now our 9th national health priority area as well.
When you mentioned the evidence led yesterday, was that from the AIHW
Yes.
witness? Now, what proportion of people living in residential aged care live with dementia?
Around 50% of people living within residential care facilities have a diagnosis of dementia, and this compares to around 10% of the older Australian population in general. So you can see that, as mentioned at the early part of the discussion today, that the likelihood of cognitive decline being a precipitant for residential care.
And what are the behavioural and psychological symptoms of dementia?
So we talked a little bit earlier in the evidence about, I guess, what they are, and there's I'd acknowledge some of the tremendous work that's done by some of the advocacy groups that are actually led by people living with dementia, such as DAI or Dementia Alliance International, that are really trying to get away from the use of the term behavioural or psychological symptoms of dementia. And you know, I'd certainly acknowledge that these symptoms are often symptoms of cognitive disability and often an expression of unmet need. These may be things such as wandering, which again, you know, the trouble with a lot of these terms is they can become slightly pejorative in nature as well. But in terms of wandering or agitation or aggression, sometimes frank psychotic phenomenon, and these are perceptual phenomenon like visual hallucinations, auditory hallucinations, feelings of persecution as well. And it can also refer to some coexisting mental health conditions such as anxiety and depression as well. They are reasonably common. Certainly, as an estimate, around 90% of people living with dementia will experience at least one behavioural or psychological symptom of dementia during their journey in life with dementia. But that doesn't mean everyone gets every symptom at once. They can vary in terms of their severity, their prevalence, and their characteristics throughout someone's journey with dementia.
And how is dementia treated?
So we have no dementia-specific treatment that will reverse or arrest the progression of any of the more than 70 causes of dementia that we have. And probably just worth talking about causes a little bit at this point is that the most common cause for dementia is Alzheimer's disease, followed by probably a mixture of Alzheimer's and one of the other causes of dementia, followed by vascular dementia and dementia with Lewy bodies or dementia associated with Parkinson's disease, and frontotemporal dementias. And those together make up around 90% plus of all sorts of dementia. But they're characteristic conditions caused by different neuropathology, so different changes within the brain. So you can see that there'd never be a single cure for dementia because it's caused by a number of different diseases that characterise the syndrome. At the moment, what we have is mainly around symptomatic treatments. So these are non-drug treatments as well, and around looking backwards a little bit as well and looking at how we can live well with dementia, and things like exercise, diet, attending to midlife vascular risk factors, so things like high blood pressure, high cholesterol, risk of stroke, risk of heart disease. Treating that in midlife has a potential impact in later life, as well as looking at other aspects of ageing successfully that have a positive impact of cognition, which again is socialisation, which is purpose, which is social engagement, which is exercise. So the treatments we have aren't a pill, aren't a particularly injection or something at the moment. However, you know, again, there are a lot of good work done at the moment to look at potential cures, and where we've come on a long way in the last decade has been around early diagnosis, because in the end, any treatment for dementia will have to involve picking people up before they develop irreversible changes.
So then, is the recommendation more around management through using non-pharmacological tools as well as pharmacological tools?
Yeah. We do have, for symptomatic treatment, classes of drugs that can, if you like, hold the symptoms at bay for maybe 6 or 12 months, but they're not always successful. And as we mentioned previously, no drug with an effect is without potential side effects. But we know the diagnostic process and attending to comorbidities. So again, when we talk about the non-drug treatments of dementia, absolutely key, but also managing associated illness, because people with emerging cognitive impairment may have problems with compliance with medications. They might not be taking their diabetes tablets or their blood pressure tablets, and thus you actually have the interaction of cognitive health with physical health, and the two driving each other. So it's about attending to the medical comorbidities as well as the non-pharmacological management.
So do geriatricians make recommendations for non-pharmacological management, such as for exercise, to an older person as a treatment for dementia?
Absolutely. And we run memory clinics within an interdisciplinary team. And again, I'd emphasise this is working with our colleagues here in terms of physiotherapists, in terms of nurses and nurse practitioners, in terms of occupational therapists and psychologists, to actually look at those non-pharmacological management. Too much, and again, I'll defer to an Adelaide resident and dementia advocate, Kate Swaffer, in terms of her term of prescribed disengagement. Is one of the things that happens far too often is being told that you have a diagnosis of dementia and go home and prepare yourself. But actually, if we take a more rehabilitative model for dementia, of actually looking at working on people's strengths and their existing strengths rather than concentrating on their weaknesses. We sometimes come out of a memory clinic appointment having spent an entire hour, and I apologise, talking to people about what they can't do rather than actually celebrating and enhancing the things that they can do. And I think within that interdisciplinary framework, there's a lot that can be done to enhance function rather than just look at any inevitable functional decline.
So is that a matter for the particular geriatrician to explore, or would a comprehensive geriatric assessment also typically consider non-pharmacological management strategies such as exercise and social engagement?
A comprehensive geriatric assessment would absolutely include that. And we've also worked through the statewide dementia network in Queensland to look at GP guidelines for post-diagnostic enablement as well. So to work with general practitioners on how they can help, promote and facilitate move towards independence.
It's obviously a large topic, and one that the Royal Commission will come back to. But moving along to a new topic, or a different topic at least, mental health. So what proportion of older Australians have symptoms of depression or anxiety?
Overall, in the community, we see symptoms of depression and anxiety in around 10% of older Australians, and this rises to anything up to 50% when we look in residential care facilities. The numbers are a little bit woolly in terms of the confidence range, and we can see that the range can be sort of between sort of 25 to about 80%. But as a ballpark figure, we see depression and anxiety being a much more common problem as people enter residential care. And there are reasons behind that, of course, in terms of looking at more reactive mood issues with a loss of independence and the medical comorbidities that we see precipitating an admission to residential care as well.
So yesterday, you indicated that you heard the evidence yesterday from the AIHW, is that right? Would you agree with the AIHW's evidence, I think it was in the written evidence, that there's a gender differential between women and men and their experience of depression and anxiety as they age?
Yes, yeah, and look, I guess the other thing is that we know that some of the dreadful impact of mood disorders in older Australians as well is that we, for example, the group that has the highest level of completed suicide is men over the age of 85 years. And this is, I think, a shocking statistic. And I think as well, we again probably reach for the script pad a little bit too early when we look at treatments. We know that when we're looking at mental health treatments, the non-pharmacological management is as effective. Talking therapies work well in older Australians as well. Cognitive and behavioural therapy probably has its limitations when people have cognitive deficits, but so do medications, and we know that antidepressants are less effective later on in the course of cognitive decline as well. So looking at those non-pharmacological and lifestyle and environmental changes have a significant beneficial impact.
How does treatment of mental health differ for older people, if at all, as compared to the general population?
Again, I think when we look at the risks versus benefits, we have to be very careful about pharmacotherapy and looking at, again, which agents we use. Agents that work well in younger Australians may have side effects that outweigh their benefits in older Australians. So it's about choice. If you're looking at pharmacological treatment, it's about choice of agents and dosage. If you're looking at non-drug treatments, it is again about managing comorbidities. It's about burden of disease and what you can do to alleviate symptoms of disease to help with mood. It's about adequate treatment of pain, and it's about looking at some of the psychosocial aspects of care as well.
Associate Professor Strivens, we've got a number of topics. I'm going to keep moving along, even though that's obviously another large topic to explore. On the topic of mobility and falls, why are falls more common in older Australians?
Yeah, well, falls are more common, and there's a number of reasons behind that. When we look at falls, we see around about 40% of older Australians will have a fall within 12 months, within a 12-month period. And the ones we're particularly concerned about are either the large falls or the 10% of these people who have recurrent falls. When you look at falls, it's often multi-dimensional. It can be due to cognition, it can be due to sensory loss, either be it visual loss or problems with balance or hearing. It can be multiple medications, and particular medications associated with falls will be ones that cause sedation or ones that cause problems with either blood pressure dropping too low or heart rate dropping too low. We know that things like environment are important as well, and that there's, I guess, the impact of individual medications versus cumulative multiple medications as well.
And what interventions are recommended?
Look, we have guidelines that we use based on the British Geriatric Society and the American Geriatric Society of actually looking at a comprehensive assessment, looking at falls risk, so looking at someone's cognition, looking at their number of medications, looking at sensory loss, looking at footwear, screening for visual impairment, and a comprehensive review of people's medications. It's important to realise that falls are often have serious sequelae of people needing to access either hospitalisation or residential care. And even in the absence of injury, that loss of confidence and that loss of self that's associated with falls can be an important psychological stress on people as well. So falls prevention is key, I guess, part of the overall assessments that we look at doing with people.
On the topic of continence, are problems with urinary or fecal continence inevitable consequences of ageing?
Not at all, and this is again, I guess, while we know that overall many conditions may increase in prevalence as you get older, they're not an inevitable consequence of ageing, as we know. Even if we're talking about dementia in residential care, there are still 20% of the population in residential care that don't have dementia. And with continence, it's neither an inevitable consequence or seen with absolutely everyone.
What management strategies may assist?
So again, interdisciplinary assessment is key, looking at reversible or remedial causes. When we look at urinary incontinence, we may see issues of stress incontinence, as when the continence issues you have with coughing or sneezing, versus urge incontinence when you don't get to the loo in time, versus a mixed picture or functional incontinence where you can't get to the loo. And I think that's where we talk about interventions. We're not just talking about containment strategies, we're also looking at regular toileting. We're looking at making sure medications aren't impacting on someone's ability to get out of bed and get to the loo. We're making sure people can recognise where a toilet is. You know, we see far too often white on white bathrooms where it's very difficult to differentiate where the toilet is, whereas something as simple as blue toilet seats can make a difference. Something as simple as lighting at night or a bedside commode can make a difference. And again, pads should really not be used as a substitute for care. It's the analogous, again, I think, to some of the issues with antipsychotics is that we should be looking at facilitating independence rather than just using containment strategies.
Is there a connection between rationing of incontinence pants and development of sort of infection?
I think we know that the sort of things that will contribute towards infection risk, especially looking at skin infections or urine infections, would be both urinary and fecal incontinence. Pads have different capacities and need different, I guess, time intervals of changing, but again shouldn't be used as a substitute for a regular toileting program. But yes, if a pad is left on too long, it will encourage a site that's that would be vulnerable to infection. And even the best pads, don't tend to take more than a litre or so of fluid, and the longer they're left on, the more likely there'd be to be a breakdown of barriers.
So on a related topic, how is skin affected by the ageing process?
So we know that we know when we're looking at the layers of skin that skin's the biggest organ in the human body and has the functions of both an organ but also a protective barrier as well. It works to control some of the movement of electrolytes in and out of the body as well. And as we age, we know that certain characteristics of the skin changes. A lot of the junctions become looser. You can lose some of the connective tissue that binds it together. You can lose some of the protective factors of fat and muscle layers that make the skin more vulnerable to pressure, make it more vulnerable to shearing pressures, which can impact on the development of pressure areas or the development of injuries. And those changes as well increase the likelihood of developing either pressure areas or infections around pressure areas, and can happen frighteningly quickly.
So how is infection risk otherwise affected by the ageing process in addition to skin integrity?
Well, we've talked, I guess, about the overall pattern of multimorbidity that can be seen, especially in frail older people. And again, I'd emphasise this is not the majority of older people, but if we're talking about people within a community care or residential setting, they're far more likely to interact with the acute care setting. They're far more likely to have, for example, antibiotic treatment. That 70% of people within residential care get at least one course of antibiotics every day, every year, and 20 to 30% get more than one course of antibiotics. This encourages the development of side effects from antibiotics as well as resistance. And shockingly, some of the data suggests that up to 3/4 of those antibiotics are incorrectly prescribed, and by that it might be the wrong agent for the wrong duration with the wrong strength. And up to 1 in 5 prescriptions there seems to be little indication for at all. So you're then going to select out the development of resistant organisms. You've also got the issue of things like, as we mentioned, the increased prevalence of continence having an impact on infection risk, the increased interaction with resistant bugs from a hospital setting, as well as indwelling devices such as catheters increasing that as well.
What practices can assist the control of infection risk in residential care facilities?
Well, when we're looking at I guess, larger outbreaks of infection, so this is talking with things like gastro outbreaks or flu outbreaks, there's the common principles of hand hygiene and hygiene fields, as well as the importance of vaccination as well, both of healthcare workers and of older Australians for influenza, as well as looking at things like cohorting as well, of making sure that when you've got strong public health strategies in place to deal with outbreaks earlier as well.
What are the implications for someone in residential care, for example, of reduced mobility?
Well, reduced mobility will impact on your infection risk by increasing the concerns with pressure areas. Will also make you more vulnerable to wounds that can be infected as well, and also has an impact on chest infections, for example. If your mobility is poor, you're more likely to get problems with the supply of air to the lower part of your lungs and develop something called atelectasis, which is where the lung bases collapse and are a more site where infection can come, as well as issues with immobility contributing to constipation, which in turn can contribute to problems with urinary continence as well, which increasing the risk of urinary infections.
Now, turning to the topic of hydration and nutrition, what sources of risk to proper hydration and nutrition arise as people age?
Well, again, I would defer to my colleagues in dietetics and speech pathology to talk at some of those risks of hydration and nutrition. But one of the issues here is again of immobility. It's also of multiple medications that might impact on someone's ability to maintain an adequate hydration. We also use multiple medications that impact on hydration, maybe causing dry mouth, or also contributing by using diuretics or water tablets that try and drain off fluid in the case of someone having cardiac failure. And the balance between adequate treatment and concerns regarding dehydration are significant. We know that nutrition can be an issue as people get older as well, and adequate nutrition, if people develop, for example, problems with swallowing, then actually obtaining adequate nutrition without the input of dietetics and nursing staff can be difficult, as well as working towards patients and people's preference around what sort of modifications to diet and hydration that they have.
So how should unexplained weight loss be managed and monitored?
Well, first of all, looking at reversible causes. So again, is this a matter of intake? Is this a matter of another serious underlying condition such as cancer or malignancy? Or is this an indication that someone is approaching the end of life, and that at that point it's actually moving more into a person-directed end-of-life care? It's also about making sure that patients' preferences are met, and in terms of looking at food choices that people want to eat, and looking at the adequate nutrition associated with person choice as well. But yes, essentially it's looking at reversible causes, and what you treat, and what you can't treat, you ameliorate.
So you mentioned problems swallowing. What are the common causes of swallowing difficulties in people as they age?
Even the act of aging itself, that some of the muscles of swallowing can deteriorate as you get older. But when we look at conditions particularly associated with it, one would be stroke, the other would be other neurodegenerative disorders such as Parkinson's disease, and in fact most dementias as well as they progress will impact on swallow as well. Can also be a side effect of medication, and we talked about medications that might cause an overly dry mouth, medications that actually sedate an individual that have an impact on the muscle control, and again antipsychotics potentially impact on the muscles of swallowing as well. So combination of medical conditions, aging and reversible causes of dysphagia are associated with swallowing.
Apart from dehydration, how else can dysphagia cause risk to people as they age?
So the other major risk that we know around dysphagia is around aspiration. So by aspiration, this is when either secretions or food or fluid, rather than going down the esophagus in the stomach, go down the trachea and into the lungs. Discoordinated swallow, and again I would apologise to the Commission that this is where we rely very much on our interdisciplinary team of speech pathologists. But the incoordination of swallow can actually mean that food or fluids goes down the wrong way. Now, aspiration of other secretions can occur independent of any modifications you might make to diet or fluid, and is again very much part of how you manage oral health as well.
Now, moving to the topic of advanced care planning, what should advanced care and end-of-life care planning, when should those topics be discussed with someone?
Look, I guess my and the Society's feeling on this is around that it's never too early to actually have those discussions on end-of-life care, and I would encourage all of us to actually have those discussions with our family, friends and loved ones about what our personal values and beliefs are, because they vary according to who you are, and they vary according to when you are, and whether or not you're in your last 100 days, your last 100 hours or your last 100 minutes. Your perspective changes with that, but we have a common set of beliefs. So I would actually encourage those discussions early on. There are particular trigger points as well. A hospital admission with a severe illness, entry to community care, entry to residential care is times when, if those haven't been discussed, they should be discussed at those trigger points. And we have, across different jurisdictions within the country, slightly different approaches to this. But I guess the concept of advanced health directives, of medical or healthcare enduring powers of attorney, are that you're actually discussing those wishes with the person before, if they ever do lose capacity as well. So it's about the wishes of the individual and clearly communicating those wishes, because it's, in the end, it's about that self-advocacy. It's not necessarily about what we want for others, it's what they want for themselves.
And how can geriatricians assist with those conversations?
Again, I think it's around those trigger points. You know, the trigger points that may look at the need for a comprehensive geriatric assessment. Part of that comprehensive assessment should be a discussion around end of life. And this can seem like a difficult conversation. And I think as a society, we're not great about talking about death. But it's one of those conversations that I think you actually, the more you get used to having the conversation, the easier it becomes. I mean, it's not a good thing to do at the time that you're necessarily making a diagnosis, but it's something that can be incorporated within that whole process of comprehensive assessment.
We talked a bit about, at the start of your evidence, and throughout your evidence really, about the role of a geriatrician. What motivates geriatricians to sort of visit ageing people in residential care facilities, and are additional motivators required?
Look, I think most geriatricians feel that the care of older Australians in long-term care is actually a core part of what we do. It's one of our core duties, and certainly, you know, that the complexity of the medical conditions that we see within residential care lend themselves to the expertise that a geriatrician can bring. The majority of geriatricians work within hospitals as well, so can actually help to coordinate care across care transitions as well. And I think that's when we're talking about how geriatricians contribute, I think it's around that integration of health services across the acute, subacute, community and residential care setting, and bringing together those healthcare and personal and social care teams as well. There is, as the Commission will be aware, an item number under Medicare for comprehensive assessment, which differentiates between both clinic-based assessment and community-based assessment, which does help facilitate that. But I'd emphasise again, this is what we'd consider a core duty for specialists in geriatric medicine.
And to what extent is the availability of those Medicare codes sort of limited by time or in other ways?
Look, I think we know that when you're looking at how you provide services to residential care, we do look at targeting interventions. We're not saying that every single person at every week needs a comprehensive assessment, but at those trigger points, that's when there's potential benefit, and it benefits the individual as well as benefiting the system. In the end, no older Australian should have to enter residential care for want of diagnosis and management of a potentially treatable medical condition.
That concludes my questions. The commissioners may have additional questions.
Thank you, Ms Bergen. Professor, am I right in understanding your evidence to be that for the most part geriatricians in this country are hospital-based?
I would say that the majority of geriatricians have at least some part of their role within hospitals, but we have fully community-based geriatricians, and many geriatricians will also have a domiciliary and community-based role as well.
Yes, well, I was going to ask you about that. Is it common for geriatricians to attend, for example, at a nursing home, or to visit somebody who is being cared for in their own home?
I think the answer to that would be not as common as it should be. It's dependent on a referral, and it's dependent on the availability of services, and those availability of geriatricians will vary according to where you are in the country. As there's significant parts of Australia where we don't have easy access to geriatricians within the community and within residential care, and in fact within hospitals in regional and rural Australia, provision can be lower as well. Having said that, there are also methods of providing that support through virtual teams and through technology as well. We've had trials of telehealth-based interventions in residential care and community, which show a tremendous amount of promise as well. So distance and availability, local availability, shouldn't limit the application. Perhaps one of the things that has limited it has been the disaggregation of health and social care, is the lack of appreciation of the need for clinical management of complex medical comorbidities through an interdisciplinary team, and the move towards just looking at accommodation. It's probably, don't take this the way that we're suggesting that residential care facilities become mini hospitals. That's entirely not the point. They are people's homes and should be set up in that way. But we shouldn't lose the opportunity to actually correctly provide the medical care that these complex, frail older Australians deserve.
Well, do you get called on from time to time, for example, to give advice to general practitioners or people who you've described as the, I think, frontline clinicians, about how to treat a particular patient without yourself being called on to go and see that patient?
Absolutely, and that's I guess one of the great advantages of trying to look at an integrated care model, and we've seen models like this that have worked in the past. The aged care panels that were brought in that looked at bringing together the hospital specialists, the GPs, the residential care facilities to both discuss individual cases as well as system-based issues was a promising but unfortunately relatively short-lived initiative. We've also done some very interesting trials looking at integrated care, of taking geriatric medicine out of the hospital and into primary care, and actually doing clinics for community-based complex frail older people within GP practices. And the advantage of that is it's where people are comfortable with going, and the knowledge and skills transference in both levels between geriatricians and GPs, as well as the other way round, I learn an awful lot from the GPs as much as I impart information, has been very promising as well. And I think there are ways that we can look at trying to drive integration. Unfortunately, a lot of our systems and financial systems at the moment create artificial divides between state and Commonwealth funded, between hospital and community, between community and residential care. Our systems should drive integration and excellence rather than encouraging silos.
I'm assuming that there are a lot of people, both in home care and in residential care, who cannot easily be moved to a hospital for the purposes of an outpatient consultation. Is there a case to be made for people at your level of the profession being funded to go to nursing homes and review the treatment of patients?
Yeah, and those existing funding levers are there. There is, as I said, there's an item number for a comprehensive geriatric assessment once a year and a review comprehensive assessment once a year under Medicare. The good thing about trying to integrate those services is that you can actually go to visit the person in situ, and I think that's we've always known as a profession, and I mean geriatric medicine grew out of that need to look at reversible or remedial causes closest to the person's place of residence, and we know that that's what people want. I think there's a risk of saying that older people shouldn't ever go to hospital, because I think that's not true, and it carries with it risks that people will discriminate against older people in residential care, saying they shouldn't go to hospital, where in fact sometimes that's the place they need to be for a short period of time to treat. But we'd much rather provide care closest to home.
Picking up on Commissioner Tracy's questions, I really had some similar issues that I wanted to raise with you. And the first, Professor, is about the relationship between your multidisciplinary approach within the hospital setting versus assessment teams within the community that apply to aged care. Are there linkages? Are there overlaps? Is there any relationship at all?
Yeah, and that's where I was trying to, I guess, get the idea across of interdisciplinary rather than multidisciplinary. I think when we talk about multiple disciplines, often they can do their own thing and come up with their own set of recommendations without it tying together as a whole. With interdisciplinary, we're coming together with common recommendations. And I think you make a very good point about the need to integrate comprehensive assessment within a multidisciplinary or interdisciplinary team in hospital and community-based teams. ACATs, as they were initially designed, actually included medical components as part of the interdisciplinary team, and we have seen a progressive reduction, I guess, in some of the medical input to that team. That there's encouraging signs in the opposite direction now, and we'd certainly encourage the involvement of geriatricians and general practitioners in that assessment. I think otherwise we do run the risk of really just assessing for a designed program rather than looking at potential reversibility and enablement. And it's been encouraging the way that we've looked more at enablement, or restorative care, or rehabilitation, if you want to use it as a different word to enablement, but we're not fully there yet. I think we want to make sure that people have access to the services they need by the people who need to deliver it at the time that they need it.
We've seen in the past, as you alluded to in your evidence, quite a few attempts at integrated care, and it becomes a key approach. We certainly saw it in the 90s and the 2000s. Why does it fall over, and what needs to occur to implement the sort of team-based approach that you're suggesting to us?
I think targeting is important. I think it can be difficult if you try and apply an expensive intervention to a large number of people. It soon budgets will blow out. So it's about targeting that intervention, and it's probably now about using new technologies as well. It is looking at telehealth, looking at video case conferencing, looking at rather than multiple paper charts, integrating them into electronic records. So that there are probably options now that will drive success that weren't there in some of the trials in the 90s and early noughties. I'm still a strong believer in integrated care, and we've been trialling a number of new initiatives in that space over the last few years. And I must admit there's some encouraging signs that I think there's probably a renaissance in integrated care.
The story that you've told today through the evidence around the range of conditions, the interrelationships of conditions, medications, and various forms of preventive treatments are fundamentally important to maintain elderly people's good health as best we can and to improve it. To what extent do the training programs for personal care workers and nurses in the aged care sector shed any light on those things for the people working in the sector?
Yeah, and I guess some of the things that we've looked at in this space has been around how you provide education support across a vast variety of different skill bases, and moving from people with essentially certificate level education through to people with postgraduate education. I think a lot of it is around, and I'm not an expert in education and training within that workforce, but what I see from our experience is around the integration of the whole team, and actually looking at all levels of training to contribute within a team, and not just having a clinical team or a health professional team and a personal care team, but having an integrated team with the ability to gain knowledge in those particular conditions. I think it is about, and it's very interesting when we talk about cognitive disability, it is once you get your concept around that this isn't someone doing something for the sake of being awkward or deliberate, this is actually around how the brain is reacting to the set of circumstances around it. It does make your approach to things different, and I don't think we should avoid the necessity for education and training support for every person within the organisation, and this is from one end to the other, including high-level executives as well.
I'm constantly interested in how whenever the health sector more generally and the care sector talks about integrated teams, each profession says they should lead the team. So the evidence that we'll hear now says the nurses might do that. I expect next week we'll hear the general practitioners might do that, because I've certainly heard that before. Your evidence says the geriatricians should. And in some ways I think there the twain shall meet. And that's really leading into my next question about how does an integrated team work, or how does an effective integrated team work in practice, so that each of the players can effectively contribute in a way they have proper exchange of information. You've alluded to that, I think, in your evidence. But as well, they're engaged in the care of that person, so that person's at the centre.
Yeah, and look, I think you've answered your own question there with actually the person driving and coordinating the care is the individual in the centre of care, rather than the what I consider one of the biggest risks to integration is tribalism between different health professions and within different craft groups. I think there are ways of, if you keep that person at the centre of care, there are ways of integrating that don't involve leadership. I was careful to use term more coordination than leadership, and I think that is where it falls apart, is if someone's got to think that they're the big boss in a situation. It's about coordination of those disparate groups, and I think that's where it comes down to, again, that concept of interdisciplinary or transdisciplinary care.
If then an elderly person or their family decides that that they would like to have an integrated team work with them about their needs so they get the best balance of drugs and so on, how do they do that?
Well, they can ask their general practitioner to make a referral to a geriatrician to access the geriatrician, and through that an interdisciplinary team. There are also other Medicare items to involve allied health teams. Again, they probably drive multidisciplinary rather than interdisciplinary care, because you're funding each individual components rather than wrapping a service around the individual. So if you're looking again at levers, you want to try and look at systems that maybe fund that whole service and the whole gamut of interdisciplinary assessment rather than individual components separately.
And in other countries where these arrangements are used, how are they funded?
Often through public health
That's what I
services.
thought. Yeah. Okay, thank you.
Anything arising out of that, Ms. Wood?
Nothing arising. Thank you, Commissioner.
Professor, you've given us enormous assistance in understanding the ways in which we provide medical services to the elderly in this country, and we're very grateful for your insights. Thank you very much for your evidence. The Commission will adjourn until midday. Yes, Mr. Bolster.
Thank you, Commissioner. I call Professor Deborah Parker.
I solemnly and sincerely
declare and affirm
that the evidence I shall give
will be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If document number WIT 0017 0001 0001 can be brought up, please. Professor Parker, that's the statement that you prepared at the end of January of this year.
Yes.
And do you wish to make any amendments to that statement?
No, I don't.
And are its contents true and correct to the best of your knowledge and belief?
Yes, they are.
So I tender, Commissioners, the witness statement. That's number 0017 0001 0001.
Are there any exhibits that go with it?
No, there aren't, Commissioner.
Very well. The witness statement of Deborah Parker, dated the 31st of January 2019, will be Exhibit 1-15.
Now, Professor Parker, you are currently the chair of the Ageing Policy chapter of the Australian College of Nursing.
That's right.
And could you please give the Commissioners some background as to the role and function of the college?
So the college represents the peak body for nurses in Australia. We have approximately 10,000 members. Provides opportunities for education, for leadership, and for advocacy, as well as providing opportunities for scholarships and grants programs.
And how many of your 10,000 or so members are registered nurses?
almost all of them, about 92%, I think it is, in the document. But we also represent some nurse practitioners as well who are also registered nurses to be a nurse practitioner.
And enrolled nurses?
Yes, about 5% of enrolled nurses.
Now, the college's courses in aged care I'd like to talk about.
Mm-hmm.
What do they comprise?
So we have a fairly comprehensive list of courses in aged care, which includes things around wound care. Have you got a list there? I think I did.
I think I
provide
have a
that.
list. There was one particular course I wanted to ask you about. That's the graduate certificate in aged care nursing.
Right.
Is that how long does that course run for?
So a graduate certificate is a 6-month full-time equivalent course.
And I believe that it involves the following issues: the assessment of the older person, clinical issues in the care of the older person, assessing and managing adult pain, continence management, dementia care, healthy ageing, Parkinson's care, wound management and leadership. That's the principal course that's offered to your members and others?
Yes, it is one of many courses around Australia. So there are universities that offer postgraduate courses in aged care, graduate certificate, diploma, master's level. So there's quite a lot of training opportunities available for registered nurses.
This sort of education, though, is voluntary education after a nurse has graduated and been registered.
That's right.
And the other people in that market would be the Nurses and Midwives Federation?
Yes, I'm not sure whether they offer courses. I presume that they do, but certainly universities are in the market of offering postgraduate courses.
Now, nurses are also required to do continuing education.
That's right. We have to do 20 hours a year for our registration.
And what content is mandated for that sort of course?
So that's about your professional development. So it really depends on the area which you practice. So for me, I'm an aged care nurse, so my 20 hours would be perhaps doing a short course on something like dementia care to make sure that I'm contemporary with that. It requires some reflective practice, so I have to set learning objectives, reflect on whether those learning objectives have been met as doing part of that course. It can be attending a clinical update session, which some professional bodies might provide. It can be attendance at a conference, and again, it's about setting some learning objectives. What do I want to learn from attending that conference, and then reflecting on that and keeping a log of that.
For the registered nurse who works in a residential aged care facility, who is dealing with aged care people all the time, is there any requirement that their continuing education embraces the field in which they're working?
No requirement. Keep your registration, you do need to be across contemporary and current practice. So it would be unusual if you were a registered nurse working in the aged care setting not to do your professional development that was related to that. But of course, that's quite broad.
And of course, in the case of nurses and enrolled nurses, their registration involves oversight by state bodies.
That's right.
Transparent legislative complaints mechanisms.
Yes, that's
and
right.
They're ultimately accountable to those professional bodies.
That's right.
So complaints can be made about them.
Yes.
Is the CLE, CLE is for lawyers, but the continuing education for nurses and midwives, is that audited by?
Yes, yes, I have been audited.
And
yes.
So the auditor would be the registration body, that's
yes.
the Nurses and Midwives
that's right.
Board?
Yes.
And it's the Nurses and Midwives Board, which is an Australia-wide body?
Yes, that's right.
And it sets the standards for nurses in terms of education?
Yes.
Now, does that extend to the requirements for their education at university?
Yes, it does.
So the undergraduate courses must meet requirements
Yes.
set by the Nurses and Midwives Board.
That's right.
Okay. All right. Now, just wanted to talk about the undergraduate courses for nursing, just to get a very broad idea. We're not going into any great detail here. That's a full-time course?
Yes, we offer it full-time, yeah.
And over how many years does it take to complete a Bachelor of Nursing?
It's a 3-year degree course.
Now, face-to-face teaching, and by that I mean experiential teaching actually in a hospital or in a residential aged care facility, how many hours are required in a undergraduate degree?
So in the complete undergraduate degree, 800 hours are required across all settings and all specialties. There's actually no set requirement for a particular aged care number of hours. In the university that I work at, we set that internally as 80 hours. So all of our undergraduate students will have at least 80 hours, either in the aged care setting specifically, preferably, or they may be looking after older people in a hospital ward. And we also have a set unit within the curriculum specifically around aged care. Some universities have it woven through the curriculum, but there is a requirement that the curriculum does address the care needs of older people.
All right. Now, in addition to that, you'd be aware that often graduate nursing students or undergraduate nursing students often work in hospitals or in aged care facilities as assistants in nursing.
That's right.
An assistant in nursing is what?
So an assistant in nursing is what we would call an unregulated worker. So it's a worker that may have a certificate qualification but is not diploma or degree prepared.
All right. Now, I just wanted to ask you about the extent to which the university face-to-face patient contact involves or embraces aged care. Is it a major part of that program, or is it a minor part?
Look, within most universities, I would say that most students probably would go to an aged care, residential aged care facility for some component of their training, possibly in first year or second year rather than third year. And as I say, in some universities we have dedicated units where we focus on that. And then there is the postgraduate options as well.
Yeah. All right. If the witnesses, if that exhibit could be brought up on the screen, please, to page 9. Exhibit 1/15. That's true. That's double. Yes, thank you. Keep going to page 9 at the foot of the page. Thank you. Now, when you were asked, or when the organisation was asked and you answered on its behalf, what you considered the most important issue for the aged care sector over the next 20 years, you indicated there the skill mix of the workforce. And I was wondering if you could please develop that concern in your oral evidence, please.
So currently we have within the workforce within aged care, and that's referring to the aged care workforce survey that's done every 4 years by Flinders University. We know that the number of, or the percentage of registered nurses has gone down from about 21% in 2003 down to about 14.9% now. So we, and correspondingly, there's been an increase in what's called the assistant in nursing or personal care worker, the unregulated worker. So I guess from our perspective, representing the registered nurses in the workforce is that we're concerned, from what we heard this morning from the College of Geriatricians, of the high level of acuity of people within either home care or residential aged care with complex needs requiring complex assessment, care planning, and as he rightly pointed out, a lot of non-pharmacological options in terms of providing appropriate care for people with complex needs. That we believe that the role of the registered nurse is crucial in this, as is the role of the enrolled nurse. So the enrolled nurses operate under the supervision of the registered nurse, but the unregulated worker with a very short certificate training with approximately 120 hours in care in the facility is not prepared and does not have the level of assessment and planning skills required to meet the needs of the current aged care clients.
Now, you say the word acuity, just so that we're all clear, that means that the complexity of the patient need is going up.
That's right.
The number of nurses is going down.
That's right.
If the page could be scrolled down to a paragraph beginning, what's the second last paragraph on the page? You mentioned the scope of practice for the registered nurse there, which you set out. If there are fewer nurses being asked to deal with greater acuity, the tasks that you list there need to be addressed in a much more stressful environment, may I suggest?
Yes, that's right.
Could you go through those issues that would appear to be fundamental tasks of a nurse, a registered nurse in a residential aged care facility?
Sure. So like the geriatricians, our role is part of that interdisciplinary or multidisciplinary team. So part of our role is to do a comprehensive clinical assessment of the either residents in residential aged care facilities or people requiring home care. We need to understand what's in that, what that assessment is telling us, to then plan the care that those people may require. It also means that we have to understand who else is in the team. So like the geriatricians, we don't operate as solo operators either. So we, as part of our training, understand the role of allied health. We understand the role that the GP plays, the geriatrician plays, and other people within the team. And so for us, it's about who might best meet the needs that we've assessed, and in that care plan, and bringing those teams together and monitoring that. It's also, we have a supervisory role, so we do supervise enrolled nurses, so it may be that we are planning care that can be delivered within their scope of practice, and then of course we are working with the unregulated health workers, so it's about setting the plan of care for them as well.
Were you here this morning when the Professor was talking about, or he listed a number of situations that require assessment? For example, continence, skin integrity, pressure areas, infections, antibiotics, etc. Who is the person in the residential aged care facility who has to make decisions and assessments about that on a day-to-day basis?
Well, preferably will be the registered nurse who has the skills in doing a comprehensive pain assessment, wound assessment, looking at continence issues. Sometimes some of that information can be collected by an enrolled nurse or an unregulated worker, but the putting that information together to then communicate with a geriatrician or with a general practitioner who may be the people who are required then to look at medication management for that person, really should come to the role of the registered nurse, because we have the skill sets to do that.
And in the last paragraph on page 9, you talk about nurses being utilised only for what you quote legislative requirements. What do you mean by that?
So in New South Wales, we have the situation where for any facility that has high-level residents, there is a requirement that a registered nurse is on staff at all times for those facilities. That's peculiar to New South Wales. But being available on site as a registered nurse, it may mean that in a larger facility that I may be tied up with other tasks in terms of doing ACFI assessments or other quality activities, and I'm not actually on the floor supervising and doing the assessments for the residents, and that might be falling to an enrolled nurse or a assistant in nursing.
Thank you for that. Now, I wanted to ask you about the people who would seem to be doing these services that nurses perhaps in the past have done, the personal care attendants. What level of education do they have in the main?
So they can either do a Certificate 3 or a Certificate 4 through the registered training authorities. As I said, there was a review of that in 2015 where they looked at the quality of that training that was available, and they found that quite variable in terms of who was providing the training and the level of hours that that training included. Also the time frame by which it was over, whether it was face-to-face or whether it was online. So they have put in a minimum of 120 hours of clinical placement for the certificate training. I'm not sure how they ascertained the 120-hour number, what that's based on. But again, 120 hours of good supervision and clinical placement may well be adequate. The problem is, because we have a low number of registered nurses within the organisations in the first place, the supervision may in actual fact be occurring by people at the same level of the worker that's being supervised. Because if you have a large proportion of unregulated workers in the workplace and that person is coming for clinical supervision, then there's no guarantees that they will be supervised by the appropriate level of person for that 120 hours.
It really depends upon the quality of the people they're placed with.
It does, yes.
And if there are no registered nurses on duty to look after them, or the registered nurses are too busy because they're run off their feet, what training do they get?
Yes, yeah.
All right.
Well, the same would presumably apply to the nursing placements that you send out into these places. If the local registered nurse is so busy, he or she may not be in a position to provide the assistance that you hope will be provided on these occasions. Has the university got some arrangements with particular nursing homes, residential care facilities that provide a degree of assurance that adequate time will be devoted to the placements?
Yes, and many we do, and many universities do that for that very reason, and that we want to be sending our students to the places where we know that there is registered nurse support. But even within those placements, though, on a very busy shift, on a very busy day, it is sometimes difficult for the provider to provide the level of supervision all the time for those students. There is some models, which is the teaching nursing home models that were around about 10 years ago, where there was much more formalised arrangements with that. I know Helping Hand here in South Australia, I think, still has that arrangement with the University of South Australia, where it's quite a formal agreement between those two organisations. And there was a number around the country, but they sort of slip away with, I think there was dedicated funding at one point to try and set those relationships up. And I think that's something that, you know, we should look at in the future around having really good relationships with between universities and providers.
And is the management of the institutions to whom you send students for practical tuition generally cooperative and want to assist in the ongoing education of the next generation of...
Oh, absolutely. The industry is very receptive to partnerships with universities and to receiving student placements. The hope is that a positive placement as part of your undergraduate training will lead to a workforce within the industry. So working with providers, you know, who are able to do that means potentially when the student has finished and is a registered nurse, that they would actually go back to that provider and seek employment, so that we can build that workforce. So yes, they're very very cooperative and keen to work with universities.
Yes, Mr. Balston.
Thank you, Commissioner. I wanted to just talk now about the training, go back to the training for personal care attendants. You said it's provided by a range of providers.
Yep.
I want to get an idea of that market. Is state TAFE involved in those sorts of programs?
Yes, anybody that's what's called a registered training organisation can provide that level of training. So while the College of Nursing is also a registered training organisation, we don't provide training for the Cert 3 and 4 worker. We provide training at the postgraduate level. So you, as an RTO, you decide what training courses that you will offer, and then you have the staff available to do that. And it's a market-driven economy, so you advertise your courses and people come to those.
The supervision, the oversight of that market, who decides what's taught and when and how?
I think it's I'll probably not get the name right, but the Australian Quality Skills Council, I think.
Right.
Yeah.
Okay. All right. Now, registration of personal care attendants. What's the college's view about that?
So, as I said, we would view assistants in nursing as what we would call the unregulated workforce in comparison to the registered nurses, enrolled nurses, where we're legislated to practice. If we have an error in our practice, then we can get reported to the Nurses Board of Australia, and that will be investigated. That if we're found that we are in error, that will be publicly available against our registration number. So you could search for the name of a registered nurse in Australia, and that is on a website. So in the unregulated workforce, we don't have that level of protection. So there is something called a National Code of Conduct that has come out for that workforce, which is supposed to be enforced by at the state level, and I think that's been variable in how that's been taken up. So that's like a code of conduct for the unregulated worker, but it doesn't give protection for somebody who may have not acted in the best interests of somebody within a workplace. There is no record of that, and nowhere to take that through other than a criminal prosecution.
Well, when you say enforced, what enforcement is there? If someone breaches the code of conduct?
Yes, it's a voluntary code of conduct. So.
And who writes this code of conduct?
Well, it's a national code of conduct that's been written. But
by whom?
I'm not sure who wrote it, to be honest. but I guess what would be interesting is I know my code of professional conduct and standards of practice, because they're freely available, for people to look at. I'm not sure how many of the unregulated workers, if you ask them, do you adhere to the Voluntary National Code of Conduct, I'm not sure how many of them would actually know that there is one.
If we go over to page 11 of your statement, at the foot of the page, you endorse a recommendation that an immediate review of current electives for the Certificate 3 and Certificate 4 take place to identify if these electives should be changed to core units. So can you please explain what you mean by that? Does that have to do with the extent to which there is enough aged care / dementia content in the training that's provided to personal care attendants?
So all of the core units are aged care specific, but they're at the level of teaching people how to provide personal care. So you know how to wash somebody, dress somebody, assistance with meals. So very much on the sort of functional side of things. There is within that pain assessment and some assessment skills taught within that, within the core units. But we have, and what the work that John Pelairs' Workforce Task Force found was that within the Certificate 3 and Certificate 4 options is a whole range of what we call elective units. So there's palliative care electives, there's dementia electives, there's medication management electives. But when you sign up to do your training, you're more likely to do the core training and not to add those electives into your program. So what he's suggesting and what we endorse is that, again, given what we've heard already this morning about some of the key issues that we're facing with people in care, should we be looking at what's in the core training within those?
Is the problem that someone could go through their Certificate 3 or Certificate 4 course, do no aged care extra components, no dementia components, and end up working in a nursing home?
They may go through without doing extensive training on dementia. As I say, all of the units are aged care specific, so they are focused on care of the older person. So that is the specific training, because in TAFE there is other training. So there's disability certificates that you could do, which is different to the aged care units that you could do. But it's a short course, and so it really is it fit for purpose for the emerging needs of the client group that we're seeing.
How short?
So it can be as short as 6 months.
So that's 6 months, that's not full time at TAFE, is it?
No, I think it potentially, it does vary because people do it in different ways. You can do it a component face to face, you can do some online, you've got your clinical placement, so it does vary.
Would you be working in the industry whilst you were doing the course, typically?
Again, it's difficult to get those figures. For some people, they may have come from a different industry and they're retraining, particularly in Australia with the manufacturing industry. So we are getting workers from other industries and they may not have started work within a facility. And for some, they're working within a facility and they're doing the training.
How many, I just want to get an idea of the content that is face-to-face learning in that course. How many hours does that course involve, whether it's full-time or part-time?
I can't give you the theoretical hours because unfortunately, because I don't provide that level of training,
right.
I didn't have that information, but the clinical hours that was set after the 2015 review was 120.
All right. Now, if we could go then back to page 8, under the paragraph numbered 5, you make some comments about the new Aged Care Quality and Safety Commission. About 2/3 of the way down the page, you say that quality outcomes for residents will not be realised through a compliance-focused accreditation approach. Now, the first question is it, in the college's view, the case that the current system, the new system, is a compliance-focused accreditation approach?
Yes.
And what's wrong with that?
So to meet the accreditation standards, and they do stress that it's the minimum level that you would require an organisation to operate at. So so what we would be hoping for would be more than minimal level, and for us to be able to deliver best practice, then we need to be able to have a system where we're measuring indicators of that best practice, and you'll see in the submission as well that currently we have a voluntary quality indicator program within the residential aged care facilities in Australia, and we actually only have 3 indicators within that.
Just pausing there, if we could bring up page 7 from about halfway down the page. That's the mandatory National Aged Care Quality Indicator program.
Yep.
It's nearly 3 years old.
Yes.
And who is involved in that program? How many facilities are involved in that program?
I believe it's about 10% of facilities are currently participating in that quality indicator program because it's voluntary. What we're calling for is it to be mandatory. Now, that's not to say that other providers don't participate in quality indicator programs. There is providers that you can sign up to where you can put your indicator data in, and they can benchmark you against similar facilities or services of similar size, and you can get that information back. So it's not that the industry as a whole isn't doing that, it's just that we don't have that on a national transparent level for consumers to see. So
we'll come to that in a minute, but I just wanted to talk about this program and just how it works. So a facility presumably enters data about these 3 criteria onto a web page, and the data's collected.
Yes.
Do they measure that on a daily, a weekly, or a monthly basis?
it's a quarterly report.
Quarterly.
Yep.
Is that best practice? I mean, you refer to an Ontario study where there's 12 factors at play. Do they? I mean, I would have thought you would need to measure those indicators more often than quarterly.
What you do is you measure it quarterly, but it's reporting for that quarter.
Right.
So you are actually reporting the number of falls for that quarter. So rather than entering it's not live data daily from your systems, it's actually doing that. The Ontario system, and in the Carnell-Patterson report, there was quite an extensive review of the US system as well, which uses what's called the minimum data set, or the MDS. And so every 3 months in the US and in Ontario, there is an assessment made and uploaded into a national system of various indicators for each of the residents. So we have that when we do an ACFI assessment when somebody enters care, and if they need reassessment. But what we don't have is that 3 monthly or quarterly reporting on a range of indicators.
So the system's been going since 2016. What is the data showing? Who collects it, for a start?
So that goes to the department. I don't know what the data is showing. I have not seen the.
Is it publicly released?
No.
So it tells the department how nursing homes in 10% performing on 3 criteria, but no one else.
No, and I think I think that is the intent, that program gets to the point where it is publicly available, and what it requires is a certain level of data to be entered into the system to be able to do what's called benchmarking.
Yeah.
So I think that is, from what I've read, the long-term plan is to do that. Now, the Victorian public aged care facilities have been doing this work on 5 indicators. So the 3 indicators that are in the voluntary Commonwealth program have come from the Victorian work. And they have been putting that data in for almost a decade, I think. What they've done with that data is also wrap around a quality program for staff working in those public hospital facilities, so that the staff are looking at that data, they're looking at the benchmarking against a facility of a similar size and similar acuity, and saying, am I within the benchmark range here? And if not, they're putting in programs of quality activities, to make those improvements. As I said, in other aged care facilities around the country, that is happening as well, in that everybody has a quality assurance program, and you're looking at your data internally and making changes and making improvement. It's just that it's not available to other people to see.
So what you're saying is that if the data, when the system becomes more widely available, was publicly available, then that would introduce a level of competitive tension to ratchet up quality outcomes across the sector.
Yes, potentially. And it also gives an idea of, last night I went on and had a look at the Ontario data set. It's an Excel spreadsheet, I can pull it up. I can see by the name of the facility in Ontario exactly their rates of falls and the indicators that they've got. So if I was a consumer, I could go on and I could have a look at that. So it also, I guess, gives the consumer some idea, of, and the reason that we have to be careful about introducing this system, which is why the benchmarking is so important, and also looking at comparing like with like, because if you've got a dementia-specific unit with very high-level acuity residents, your falls rate may be higher than if you've got a unit where you've got people who are more independent. So you can't just look at the raw figures. So it is a complex system to introduce, but certainly something that obviously the department is interested in and working towards. And I guess, we would want to see that just, pushed along as quickly as possible.
You say that the individual providers do this themselves. Are there programs, are there software that they can buy that do this sort of process for them, for their own purposes?
Yes, so the departmental one has its own web page where you go in and you enter your data. As I said, there is other companies around Australia where they provide the software for you, so you enter your data and it produces graphs and tables and reports. And then some providers do it internally, so if you're large enough you may have your own business analysts where you're producing your own reports.
Tell me, you may not have the expertise to answer this question, but for a large provider with multiple facilities across states, or even within a state, say they've got 15 or 20, do you understand that they keep these sort of statistics?
Oh yes, absolutely. It's part of meeting your accreditation standards. You need to show that you're able to provide the level of care that's set by the standards, and as part of that you would keep that level of information.
So that sort of information goes to the standards, does it?
Yes.
Does it? Would that equate with the sorts of indicators that we're talking about in the Ontario study?
Yes, similar. And one of the difficulty things about these quality indicator programs is how you measure the person's experience of care. So it's much easier to measure concrete things like, did you fall? Didn't you fall? Do you have a wound? Don't you have a wound? And much harder to measure experience. But there is now, and in the submission we do refer to the consumer experience reports that are now done as part of accreditation visits, where they interview 10% of, and they've come up very positive, those first year of reporting of those consumer experience reports.
the consumer experience reports really go to more factors about how the person feels in the nursing home, the communication, things like that. It doesn't really address, and you wouldn't expect a resident to be able to address the sort of statistical care issues that this sort of approach needs to
But
address.
to provide person-centred care, of course, we want the whole experience and not just the clinical indicator experience, but the whole experience.
On a related topic, moving to the top of page 7, under the heading lack of robust and integrated data systems, this would seem to be fundamental to what we've been talking about. What sort of data collection should the industry or the sector be moving towards? Should it be seamless? Should it be across the entire sector?
Yes, not only across the aged care sector, but what we're also talking about is that many people interface with the primary care sector and the acute care sector. And so if I transfer somebody to a acute care hospital, the records sit within the acute care hospital and I don't have any access to those records. The GP doesn't have access to those records. I don't have access to the GP records. My records sit with me. There's a level of reporting that goes through to the Australian Institute of Health and Welfare, who you've heard from, in terms of some of the data. But even they struggle to link people's journey across the system and to understand what happens to people when they move from, say, a home care package into residential care, in and out of hospital. They have to do what's called data linkage to be able to understand that. But they can't pull that easily, that information easily.
Now the new website, the MyCare.
Yep.
Does that fulfil this function?
The My Aged Care? No.
No. The new system that we all now have, unless we've opted out.
My Health
Record.
Record.
My Health Record.
My Health Record.
Look, it is starting to fulfil some of those gaps, and again, hopefully that we will get there over time, where that is an area where we will be able to have that centralised portal. But at the moment, I think there's not enough data within that.
All right. Now, there were 3 other issues that you address in your report about that involve the need for further training, and they were dementia, mental health in the aged care context, and palliative care. Mm-hmm. Now, I think we've dealt with the dementia side.
Sure.
Can you tell the commissioners what's the tension that's at play in a nursing home with an older person who has a mental illness, as opposed to dementia or other problems that they may have? What's the problem in the care patient or care resident interface when it comes to mental health?
So you see the figures that one of the major mental health problems for particularly people in residential aged care is the issue of depression and anxiety. So you can have an assessment made as to whether you do have depression or anxiety, and a care plan can be developed that may include pharmacological management or non-pharmacological management. But we are not mental health nurses. We are not trained in providing mental health, and so I think we don't have that level of expertise that was referred to this morning in terms of how do we manage from a non-pharmacological point of view dealing with people with depression and anxiety who also have potentially dementia as part of that. So I think we do need to think about the training skills required, and whether that's from a professional development point of view of having more skills in that area.
Now, with palliative care, I know that's a particular research interest of yours. Is it effectively the same situation?
Yes, although the Department of Health has invested substantially in in providing funds for upskilling the aged care sector in palliative care, which has been, well received by the sector.
What does that program involve?
So there's been a number of programs. I'm involved at the moment with a program called End of Life Directions in Aged Care. It's a 3-year program funded by the Department of Health where we're providing online resources across the sector and also to GPs where we outline and provide education, online education to people within the industry about palliative care and advanced care planning. There's also, we're looking at some quality indicators specifically around palliative care because we don't have those quality indicators, so there's work done around that. The program prior to that was called Decision Assist, and I was involved in that, and that had face-to-face workshops around the country over an 18-month period where we were educating staff around advanced care planning and palliative care. So there is improvements in that area, and there is quite a lot of education now available for staff around that.
Does that extend to the personal care attendants?
Yes, it does. Yep.
Thank you. Now, just before we conclude, at the end of your statement, you refer to some good news, some innovation that you wish to highlight. Can I firstly take you to the technology situation, because I understand that is a very, it's a matter of great interest to the Commission. The situation in Singapore with the linking of databases and analytics, could you please explain to the Commission just how that works? How pervasive is it?
Yeah, so they have one centralised electronic platform for their health records. So in Australia, because we're federated, in New South Wales we use a particular electronic record system. In Adelaide here you use a different system, and so again with the Australian Institute of Health and Welfare, if they want to know what happens to around the country, they have to amalgamate information from the different systems, and then the aged care system is different again. So it's about that talking between systems.
Doesn't the Federal Department of Health keep its own national system, or does it have to import data from the states?
No, they have to import data from the states.
Right.
Yeah.
So in the aged care context, how could this improve the ability of a nursing home or a nurse or an enrolled nurse to care for a patient in real time?
Yep. So what we really want to know is if a person has been transferred to the emergency department or the acute hospital, and then they return to you after a day, 3 days, 5 days. What would be really useful for your ongoing care planning and meeting the needs of that person is for us to be able to log into that system and actually see what happened. So what happened when they arrived, what were the tests that were done, what was the treatment decision, and that would all be available seamlessly. And at the moment, what we get is a discharge letter or, outlining roughly what went on. So
You mentioned innovaging that is being dealt with by laser.
Yep.
Does that go anywhere near towards this sort of situation?
No, they're probably more at the level of innovation within the industry. So looking at more linking the providers with the tech companies for things like smart housing and other sort of innovations around that sort of level of technology. Really, the only people that can sort out the records management systems and technologies are at the level of the government.
All right. Can we turn then to the geriatric outreach and in-reach services?
Yeah.
Why are these so good? What's the secret to having a good outreach service, and what difference can it make?
So these were set up, and I've just given you, one example there of the geriatric rapid acute care evaluation, or the GRACE service. Acute hospitals recognise that many of the people that come into the emergency department or their hospitals are coming from residential aged care facilities, and they're coming into the emergency department because a GP wasn't available after hours, or they haven't been able to get somebody to do an assessment or even write a script, for somebody that requires a review of their medications. So the idea of these outreach services is that you can ring your local service, and you can say what the problem is, and they can get somebody out to you, or they can provide assistance over the phone. And what they've shown is that they can reduce the number of what would be called inappropriate admissions to the hospital by getting those teams out. Yeah. And so they often have a geriatrician, they often have a nurse practitioner, people that are skilled in aged care.
All right. And finally, the nurse navigator. What does a nurse navigator do?
So that's a program in Queensland, and because I'm not currently working in Queensland, I'm not completely familiar with that, but I think it's looking at that coordination model for people with chronic and complex care. So that was again discussed this morning of, is there a proportion of people where it is actually very difficult to navigate the different parts of the system, the primary care system, the acute care system, the aged care system, and having somebody shepherding you through that may actually improve your outcomes.
If it was easier to navigate through the system, perhaps the nurse navigators would be able to do clinical, practical
nursing. That's right. We wouldn't need a nurse navigator. Yes.
Right. That's the end of my questioning. Thank you, Commissioners.
Professor Parker, I just want to get a sense of what it's like out there in the real world in respect to care planning. Do I understand from your evidence that the person principally responsible in an aged care facility for constructing care planning is the registered nurse?
Yes, that's right.
And is that done in consultation with a general practitioner, perhaps a geriatrician?
Yes, and also allied health is very important as well. So there may be input from dietitian, speech pathologist, social worker, physio, OT. So it is it is the comprehensive assessment that's important to meet the holistic needs of the person. And
does that mean that the registered nurse has to seek out these other members of the team, for want of a better word, that is looking after an individual resident and coordinate their activities? Or do the members of the team actually sit down periodically and review the particular patient, the care that patient is receiving, and discuss how that could be improved? Yes.
People do get a comprehensive assessment, certainly on admission into a service, and then at regular intervals. How that is structured may include all members of the multidisciplinary team coming together at a team meeting. It may be done more with people using electronic system where they're writing reports that go to the overall picture of the person. So it really depends on how that service operates.
And presumably this whole process is dependent for its success on all the people involved being fully informed about the medical condition of sometimes complex conditions.
Yep.
And do I understand from your evidence that that could be improved if there was a single medical database for each resident that is got on it their medical history and a lot more detail than is there at the moment.
Yes. You probably remember some people, when they enter a residential aged care facility, may have moved out of the area in which they've lived for many years or all their life, and their general practitioner may not be able to visit the facility on which they've relocated to. And so that general practitioner may be meeting that person and the family for the first time, and trying to get the sense of what's your history, what are all the needs, what's your medications, and so they don't have a lot of, depending on what's coming to them from the different services, what the complete clinical picture is for that person.
How then does the health record help that? Will it provide that kind of comprehensive information, or does it fall short?
Look, potentially it will, and again, it depends on the uptake rate of that, because it's voluntary, but I think that's where we would want to get to is if that's going to be the central repository that we're going to be relying on, but also there will still be a level of detail that's not potentially in there, where greater interface between the sectors would also assist.
Yeah, because doctors have a similar problem with the discharge of people from hospitals as well. They just don't at the moment get enough information. Yeah. Can I go back, if it's okay, to your earlier evidence about the declining proportions of registered nurses providing aged care versus the increase in personal care workers? Is this happening by accident because the sector is growing so quickly to deal with the demographic pressures, or do you think that there's a move by providers to change that mix to a level of staffing by qualification that they think more appropriately meets the people who are receiving care?
I think it's a complex issue. It's partly that there is a particular funding envelope, and we know that, and so there is no legislation that says you have to have a registered nurse on duty 24 hours a day, 7 days a week. You have to have the skill mix required to meet the needs of the resident or the clients. So individual providers will make that decision. Partly it's in some rural areas, it may be a supply and demand concern, in that it may be harder to attract registered enrolled nurses to the sector. One of the reasons it's hard to attract registered enrolled nurses to the sector, though, is because we have a small number of people within those positions, and so if I go to work in an acute hospital, I will have a level of support that I won't have necessarily in the aged care industry. So it's a complex problem. Again, we're not probably training people to through the university training. We're probably not getting enough interface with the sector that says, I really want to make a career in the aged care sector, and it's attractive. You do get paid less in the aged care sector than you do in the acute sector, so there's a pay differential as well. So you have to weigh that up. So it's a problem with multiple issues, I think, to solve. Is it just is it legislation? Is it remuneration? Is it the image of the sector within our industry? Is it the competence or the confidence as a new graduate? We don't have many new graduate programs within aged care either, so that means that my exposure as a new graduate, as a registered nurse, will be in the acute hospital, and so that's my comfort zone. And so I need to be, exposed more into the aged care arena, which is what happened to me when I finished my training. I was fortunate, to my first job was in aged care, and I've stayed ever since. So, and it was a good experience.
And am I correct in saying that the National Disability Insurance Scheme excludes nursing care? So the real issue in terms of the competition for the workforce is between the health system proper and the aged care sector.
Yeah.
Yeah. Okay. Thank you.
Anything arising?
Nothing
from
arising.
Mr.
Thank you,
Bolster?
Commissioners.
Professor, thank you very much for your evidence. It's given us a lot to think about how individual aged care people are being cared for and how we can improve their lot. And we'll certainly be taking on board all your evidence. Thank you.
Thank you.
The Commission will adjourn until 2 o'clock. Yes, Mr. Bolster.
Yes, thank you, Commissioner. The next witness is Ms. Annie Butler. I call Ms. Annie Butler.
I solemnly and sincerely
I solemnly and sincerely
declare and affirm
that
that the evidence I shall give
the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If document number WIT 0020 0001 001 could be brought up. Thank you, Commissioner. Do you have that document in front of you, Ms. Butler?
Yes.
That's
I do.
your statement, or it's your amended statement?
Yes.
And do you wish to make any amendments to that statement at this stage?
No, thank you.
And are its contents true and correct to the best of your knowledge and belief?
Yes, they are.
Commissioner, I tender the statement. I'll be tendering other documents, but if I could do those in seriatim.
You want to do that separately?
Yes, thank you, Commissioner.
Yes, very well. The amended statement of Annie Butler dated 1 February 2019 will be Exhibit 1-16.
Now, Ms. Butler, you are the Federal Secretary of the Australian Nursing and Midwifery Federation.
Yes.
Now, that organisation has two distinct hats, doesn't it? One, it's a political organisation and it's involved in political campaigns at a whole range of levels.
That's right.
And on another level, it deals with quality, safety, educational issues on behalf of its members, the nurses, the enrolled nurses and others in the broader health sector.
Indeed.
Now, the federal body is essentially the collection of state and territory unions. Is that a fair enough description?
That's right. We describe ourselves as the union and the industrial and the professional organisation for nurses and midwives and carers across Australia. It's a federated structure comprising 8 branches from each state and territory.
And within each state and territory branch, there would be politically focused units, and on the other hand, there would be units that are focused on more professional issues associated with care, and in particular here, as we're focused on aged care, you would deal a lot with aged care related issues,
Indeed,
correct?
across the country.
There's a degree of overlap, obviously, between the two spheres, but I would like to focus, if we could today, on the quality and safety aspects of the aged care, unsurprisingly. And I'd like to start by talking about barriers to the retention of staff in aged care. Let's start with that issue. What are the significant barriers that stop nurses remaining in aged care?
What we hear most often from our members now is the increasing pressure they're experiencing with workloads. So many of them across the country describe their workloads now as unsafe, they're untenable. They report to us that that's why they're leaving the sector and increasingly leaving the sector. And that's across both nurse and carer members. For nurses, so nurses includes registered and enrolled nurses, that also encompasses a tension because they have a professional registration, they have specific requirements, they find increasing difficulty in being able to meet both their professional obligations as required of them under the national law and then employer expectations.
Right. Is remuneration a barrier to retention?
Remuneration is definitely a barrier when you're trying to recruit into the sector, and when you've got the public system, the private hospital system, a whole range of other systems that are offering not more attractive pay, but also more attractive conditions and a whole range of more attractive both professional opportunities and professional supports.
Let's talk about that. I'd like to give the Commission a snapshot of where remuneration is for aged care nurses. Could we bring up the two documents that I've listed to the Commission staff? That's RCD 999 0001 105 and 112. And you'll see that the two documents, Ms Butler, are side by side.
Mm-hmm.
Now on the left we have a calculator for the New South Wales Public Health System Award. So it's not the award itself, but it's a ready reckoner that your members can go to on their website, on your website, and see what the rates of pay are. And on the right hand side we have a generic enterprise agreement from an organisation for this point will remain nameless, but you can assume that they are a large organisation with multiple facilities inside New South Wales in the aged care sector. If we could go down a page on each, please. Now, I hope it's clear enough. Commissioners, does that need to be highlighted?
No.
All right. If we could just start towards the bottom of the page, you'll see there the pay rates for registered nurses and midwives in each operation. So for a graduate first year nurse in the state sector, which is on the left, they start out with an hourly rate of around $31.60.
Yeah.
And the comparable position for the registered graduate nurse in the private organisation is $31.89. Now, if we go down to the 8th year, this particular graduate has been in the system for 8 years, and we see a differential immediately. If we could, we're still back on the same page. Sorry, both should be on. Yes, that's correct. So by the 8th year, in the public sector, the hourly rate is $44.34. You see that?
Yep.
And whereas in the comparable situation, it's only $39.65. So there's a very gradual uptake in salary over 8 years for a nurse in the aged care situation, and this is a registered enterprise agreement in New South Wales. What's the position after 8 years? What happens to nurses' pay after 8 years? Does it go up incrementally, or have we effectively reached the ceiling for a basic registered nurse?
You reach the ceiling in terms of if you want to stay within the RN category, but of course, overall general wage increases are negotiated for each agreement, so it does continue to progress. If you take the example of, say, the New South Wales Public State Award, then nurses have significant choices about where they might want to go. They might want to stay as working as in a registered nurse classification, and that's where they stay, or they might want to go into clinical nurse education, specialisation, etc.
So, if we could go to the portion of the page that deals with the clinical nurse educators for the hospital system, and we see that, well, let's look at a clinical nurse at the foot of the page, a clinical nurse midwife specialist. It's grade 1, year 1, and we compare that with the same position in the aged care sector, which should be on the next page of that document, on the right. Sorry, we just need to go on the document on the right, we need to go one more page on. You see there, the comparable rates are quite different even there. So your clinical nurse specialist in the state system's on $46 an hour, whereas in this particular facility it's only $40.96 an hour.
The classification is also slightly different because we looked at the clinical nurse specialist in New South Wales. They also have a clinical nurse consultant, which is the classification you're comparing it to in the other agreement. So it's not just that the pay rates don't match, but the types of clinical, extended positions you can go into are also much less in the aged care sector.
Well, that's understandable. In the state sector, you have multiple hospitals across multiple area health services, and the scope for work is virtually limitless.
Yeah.
Whereas in the aged care sector, providers really have the same organisation. It is a residential aged care facility, and they have patients. They don't have surgical, they don't have midwifery, they don't have neurology. They have face-to-face care to older people. That's basically it, isn't it?
Well, that's true. We would still argue that there's a level of specialisation involved that doesn't exist as it should in the sector. We've heard this morning from our medical and nursing colleagues about some of the areas that are unique and specialised areas to the elderly populations. Of course, it doesn't have surgery. You don't need all the expansive layers of extended clinical expertise that you do in a big public health system, but we would argue that you probably need more than we have, particularly while we have classifications existing in many of these agreements across the country. We don't have many people in them.
Yeah, right. But is it your experience that remuneration overall at all levels in the state health system is better than the equivalent in the aged care sector?
Yes. What we're looking at, the examples that you have shown actually happen to be typical of what the average pay gap between aged care sector and public sector across the country, the nationalised average.
All right. Now, can we explore how that happens when you're negotiating an award on behalf of your state public sector members? I would anticipate that you have much more bargaining muscle with government. Is that a fair assumption?
It's a completely fair assumption.
All right. And when you're negotiating an enterprise agreement with a not-for-profit 50-bed residential aged care facility perhaps in regional New South Wales or even more remote than that, what bargaining power do you have with the provider?
There's a number of factors involved. As you indicated earlier, obviously we're dealing with a public health system that is an enormous system with all sorts of levels of expertise in the system, significantly HR expertise, industrial relations expertise. You know, might not always agree initially, but we respect the expertise. What we find multiple things in the aged care sector, but one of the things is that, so you've said there's this 50 bed facility. Is it a standalone? Is it part of a big aged care operator? There's all sorts of factors.
Well, if it's a standalone,
Yep.
I'm wanting to tease out the two different levels of bargaining power.
Okay,
The
so
standalone facility, what's its bargaining power against?
Well, you've got 40,000 employees, and members, 30, and we might have, 50. We'd have there might not be many RNs in the sector. The care workers could be covered by us, they could be covered by another. We do have joint agreements around the place. We might not have many members. What we also have is, because of the long-term nature of care, we have people, two things we have because particularly in one of those small facilities like that, there's a very direct relationship between the worker and the management. That eyeball them all the time. The other thing is that, and they have a long-term direct relationship with the clients, the residents. And so that is often used as a tool in terms of trying to bargain. We also have this complication that in the aged care sector broadly, the funder is not the employer. So when you go to questions of, well, what's capacity to pay, what's capacity, the funder sits separate, and the opaque nature of the system makes it very clear, very difficult to work out what capacity really is. There are also other complicating factors.
Yes, please.
Because, and expanding just from your 50-bed example, the industry itself is still a little bit cottage-based, is now consolidation with large corporations. So there's still the mixed nature of the sector. And one of the things is, especially in those little ones, they don't have IR expertise. Even the bigger ones we find don't dedicate time to getting better IR expertise, and we often find that communication from employers to employees in the aged care sector is very poor. That is complicated by the fact that there are many people who don't have English as a first language, that they also tend to be, they're a transient workforce, the low paid and gendered, they're very much a female workforce. Yeah. They have significant impacts. They tend not to be IT literate. Communication from us even to our members is difficult. Right. So all those factors compounding against us, single employer, 40,000, members, that's a much more direct negotiation.
Right. I want to move on to another topic, if I may. Firstly, can I tender as a joint tender the two documents on the screen? That's 112 and 105.
You'd better read onto the record the title of both documents.
I will, Commissioner. It's RCD 9999 0001 0105 and RCD 99999 0001 0112.
What is the title of the award that's the subject of the first tender?
The Public Health System Nurses and Midwives State Award 2018 for New South Wales.
And the other document is an enterprise agreement with an unnamed employer.
Call it a generic Health New South Wales enterprise agreement to 2018.
Well, in that case, the Public Health Award will be Exhibit 1-17 and the Enterprise Agreement will be 1-18.
Thank you, Commissioner. Now, if this document could be brought up, ANM 0001 0001 787, please. Ms Butler, this is a survey that the Federation carried out of its members and others in aged care in 2016.
Indeed.
It's titled the Nurses and Midwives Federation National Aged Care Survey. What was the process that was adopted to survey your members and others about the sector?
The process was an online survey. Is that you mean that kind of process?
Yes.
Yeah,
How did it work?
Yeah, how did it work? So we used SurveyMonkey, and we advertised the survey online and through our branches and in just general Facebook. Facebook's a useful tool for communication to not just members, just people working in the sector, and also to community members, relatives, friends, other interested people.
If we could go to page 7, which is 793. You'll see the number of participants in this survey. It's quite a large survey, almost 2,400 participants across virtually all of Australia. If you go over the page, you'll see that a very large proportion of them worked in aged care, just around half by my brief calculation. You'll see that in the second graph, at the top of the right-hand page of the screen. And if we could go forward to page 10, the survey addressed people from metropolitan, regional, rural and remote in those particular proportions. You see that? Now, I wanted to ask you about some of the feedback that you received, the anecdotal feedback. It's quite confronting when you read it. And there are a number of matters that I'd like to take you to that I think bring out some of the issues that the Commission's looking at. The first one I'd like to raise with you, so this is, correct me if I'm wrong, this is actual testimony of people through a computer survey, an internet survey of your members, correct?
More broad than our members.
More broad,
Yeah.
okay. If we could go to page 25, which is page 811. And the third paragraph on the page, commencing with the words "I have been." This deals with retention, and this is an account of why someone has left the workforce. It says here, "I have been a registered nurse since 1972 and worked in aged care since 1988, and for almost all of that time worked in senior management positions running large aged care facilities for the same not-for-profit organisation. Last year there was a roster review at the facility I was running, and the organisation made the decision to cut 16 hours per day from my care staff roster. The only option I had was to resign, as I could not stay and work under those conditions, knowing that the care I would be responsible for delivering would not be of a high standard. I'm now working as a registered nurse, 7 shifts per fortnight in an aged care facility for another not-for-profit organisation, and they have just reviewed their staffing hours and are going to cut 9 hours per day from the care staff roster. I'm saddened and disillusioned with aged care and fear for our vulnerable residents and the standard of care they are going to receive. Now, how typical is that of the situation that is conveyed to you by your members across the country?
Well, unfortunately, it's an increasing situation, and in this survey we describe, obviously comments get pulled out because they reflect the broader views, but these are the consistent themes that we're hearing from our members. Earlier today we heard about the increasing acuity in the sector and the declining skills in the sector. So this is an example, and so many nurses in the sector, care workers as well, they're there because of their love for the job. And this is someone who, after all these years, is having to leave the sector she loves because the primary concern for nursing is she can't give the care she knows these people need to receive. And she feels no option but not to be part of that system anymore.
And the next, if you could go please to page 24, which is page 810. The fourth paragraph on the page. In fact, I'll read the paragraph before it and that one as well. If we could just go back up one paragraph. 1 RN to 60 residents for day hours only. Does that come as a surprise to you, that sort of ratio?
No. Well, unfortunately, that's not the most extreme.
Right. And it says here, what happens when our residents are sick during the night? The policy is to call the ambulance. The paramedics get very upset with us because we are wasting their time. However, this is what we must do for action to be taken. You heard what Professor Parker had to say about some programs that are sort of gradually being implemented around the country that involve access to hospital call-out. Just pausing there, what's the Federation's understanding of the prevalence of that sort of program?
If I could be so bold. So one of the things with those programs, it is excellent to have nurse practitioners visiting facilities, general practitioners. There's just not enough, and there's not enough allied health support staff, all the things that we need to keep people well. The problems with some of those programs is not at all the problem with the program itself, but this concept of a flying squad to come and patch up problems that actually the facility should be responsible for managing. And so that will, am I allowed to say? That's a public health funded, like a state health system funded program that's actually reaching into a Commonwealth funded program, and because of its failings, the state's having to pick up the pieces. No. So that is not to say that those outreach programs, that nurse navigators, that all of those things in place aren't wonderful things, and the big benefits we should be looking to gain from them, from our perspective, is how do we have better integration between aged care, primary sectors, when do we need to interface with the acute sector, all of those sorts of things.
We'll be talking shortly about working models and staff modelling, and the next quote seems to be a lead into that. It says here, most aged care workers want to provide the best care possible, but are just not afforded the time. I remember as an AIN, that's assistant in nursing, I would plead with management doing the math and showing them that I would only have 15 minutes with each patient in the morning. I'd be expected to shower and dress and attend to the needs of high care dementia patients. I was just told to work on my time management. It is sad that such love and compassion goes into a career in aged care, but so many are chased away by a lack of support, worse wages, but such high expectations. I hope that things can change for the better. I want to turn to the question of food.
Can I just say something?
Yes.
That is a story we hear all the time. Just again and again and again. And people are time clocked. You've got 6 minutes to do each shower.
On page 23, there is this history. It's right at the top of the page, the first paragraph. Staff who are always rushing between tasks cannot give quality time and care to frail elders. The food is also a problem. It is often not nutritious and well presented. Food is important when you are in aged care. The meals break up the day, and good meals provide pleasure and nutritional value. Hygiene is an issue. Dirty hair, infrequent showers. Residents have the right to refuse, but when does a refusal become neglect? Qualified staff are expert as working around refusal. They have the skills to persuade an elder that a shower or bath is needed, and afterwards the resident is clean, happy and cared for. Relatives can then feel assured their loved one is being well looked after. Toenails and fingernails are another problem. Staff just don't have the time in the day to do these tasks, so family end up having to help. That wouldn't come as any surprise to you, would it?
None at all.
All right.
Am I allowed to make extra comments?
Yes, please.
Because one of the important things in here is about, of course, person-centred care is at the heart of nursing, and we heard about that earlier, it just is. But there's a thing about you've got to respect residents' right. But this point that goes to talking about, well, what do you do with a resident's refusal that you know is maybe not going to lead to ultimately the best outcome? And so there's so much talk in the sector about respecting residents' choice. But to do that, what you need to do is involve the resident in the processes and the decision making and the steps involved. That takes time and skill.
Correct me if I'm wrong, but just from listening to the experts in these sorts of things over the last couple of days, it would appear that some considerable training is needed for someone who's a personal care attendant to be able to understand what's going on in that situation and to have a strategy that they can call upon to get a result.
That's right, absolutely.
Is that sort of training prevalent?
No, absolutely not. And Professor Parker went to some explanations of it earlier today. And one of the things that we have, and I have to say yet again, we're looking at the failures of yet another structure and another system. Whereas the VET system, so how it works is you have this Australian qualifications framework, you have these level qualifications, everyone can pull out the Certificate 3 qualification and then deliver it if you're accredited as an RTO. The thing is that these qualifications are competency-based, so they don't have curriculum hours built into them. What you tick it off by achieving competency. So we know of some of these courses that are done in 2 weeks online. We know that wonderful courses are done by the TAFE system and some other good, including a couple of our own branches, 18 weeks, the best the course could possibly be. One of the other things is that trends, fashion changes, so we'll go into, let's specialise. There used to be very good personal care units of competency, we call them, in the qualification, and then the fashion will be, no, let's not be specific, let's be more general. And so providers will even complain that they don't get a person coming out of the system who has the specific understanding required to deal with the elderly. That's even in some of the better ones. And so then they struggle, and the person, of course, has gone in good faith to try and do a qualification that they think is going to deliver an outcome and lead to reasonable employment. One of the things that is being done is the establishment of the Aged Services IRC. So that has been an outcome from the work that's been done by John Polaires, and because one didn't exist. So he chairs the Australian Industry Skills Council that sits over 66 different industry groups, and there wasn't one for aged services.
Yeah.
So that we hope, working with them, to now let's build proper qualifications that are going to be better.
So the Federation is involved in that process with Professor Polaires?
We absolutely are, yeah.
There's just two more portions of this that I need to get to because I think they pick up themes. On page 22, about a third of the way down the page, the largest paragraph there, this is about the time staff are afforded to deal with matters. It reads as follows: there were 53 residents, including an 8-bed special care unit, and 85% of these required high care according to their ACFI scores. We'll come back to what ACFI scores are in a minute. Overnight, there were only 2 PCAs registered and an RN on call.
Mm-hmm.
These staff were expected to wake residents at 5 to commence their personal hygiene tasks. If they didn't do this, the morning PCAs would be openly angry because they didn't have time and weren't able to help all the residents with their personal hygiene according to their needs. Both morning and afternoon staff were rushed, and therefore the residents were rushed. There was an RN rostered on both morning and afternoon shifts. The afternoon RN was required to administer all medications during all the evening rounds. As a result of the staffing levels, the facility has a high rate of falls and medication errors. The RNs are too rushed to monitor the staff, leading to a culture of bullying, and there's no safe handover process for the RNs given the gap during the night. Just pausing there, I just want to talk about ACFI scores. The ACFI, for people that don't know, and I expect there's a lot of people watching that don't, that's the aged care funding instrument, isn't it? It's fair to say that it is a calculation that sets out in minute detail every dollar that a provider receives for each resident in their care.
Mm.
And it calculates the benefit of the Commonwealth grant to them by reference to their needs, and they're classified accordingly. We won't go into that now, but it's fair to say that the dollars are allocated on the basis of the particular need, and the particular need takes into account what actually has to be provided for that resident on a day-to-day basis. Is that a fair summary?
That is a fair summary. The sector just refers to it as ACFI, is how the way they phrase it. And so it has 3 key sections, if I could, and they're called activities of daily living, behavioural section, and then complex healthcare domains. And then there are different domains in those sections. And yes, a resident is assessed, and they're assessed of what their need is in each of those domains. They get added up to what the funding will be from the government for direct care needs. There are other funding mechanisms and stuff, but for direct care needs, yeah.
Okay, so when that funding finds its way to the provider, and the provider has those funds in its keeping, what regulation, what standards, what controls are in place about ensuring that that funding is delivered in the way that the test provides for?
The short answer is none.
Yeah, I had a feeling you would say that. All right, we'll come to that later in your evidence. Finally, with the survey, I wanted to touch on this last case. If we could go to page 20, and I can indicate that it is unpleasant, this topic, but it seems to, in my submission, Commissioners, articulate and bring together a number of issues where things can fall down. Unpleasant as it is, this is from an agency nurse. Just by way of background, are agency nurses members of your association?
Yeah. Or if they choose to be, yeah.
And what's the prevalence of agency nurses in the aged care sector?
High.
Do you have any statistics or any background that you can assist the Commission to understand just how prevalent the reliance on agency nurses is?
I don't just it's in the top of my head, but I know that the Pillaire's work, he will talk around a range of 15 to 30% of having to use and fill positions that way across the sector.
Right.
Yeah.
So let me read from this. I worked as an agency nurse in an aged care facility. The PCAs told me that the gent in such and such room required Panadol routinely at night to sleep. I asked further and was told the gent, who was aphasic post-CVA, that is very vulnerable. CVA is that he's had a cerebrovascular
A stroke.
accident, which is a stroke.
And aphasic means you can't speak.
Yeah. And he had a sore penis. He was grimacing as I approached and asked if I might look. He nodded. He had a urinary catheter in place. And instead of exiting from the meatus, the glands had a split down the side to the level of the shaft. I'll pause over some of the words that follow. I'm still horrified to this day. The wound was not new. It took time to erode through. With pressure from the IDC, that's the
Indwelling catheter.
indwelling catheter, thank
Sorry.
you, tunnelling into his penis. The GP had not been informed, and obviously I faxed them a message there and then for urgent review. A follow-up shift, he was in hospital for an urgent urology review, and it says, I am blown away the staff did not report the erosion as it was happening. Take steps to prevent it. More educated staff had not looked at the source of his pain. He had Panadol every night. That is an extreme case, but let's just pick it apart. One would have thought, firstly, when the gentleman comes back from the hospital after the stroke, there would be a handover, some sort of handover between the hospital and the facility about his ongoing care, and there'd be a care plan in place.
Yes, there should be.
Certainly when the casual came on duty, you would expect for someone in his situation that there would have been a handover from the nurse who had his care before that.
I'm going to say that these things clearly should happen. It's obvious that they don't always happen.
How often do they not happen in your experience?
We hear from members that handover is one of the areas of greatest concern. It's one of the areas that tends to get missed and sometimes is not even allowed. Particularly, and as another example said, we don't know. So that's just a de-identified, isolated, particular example. We don't know whether there's always an RN on duty. We saw in another example, is there one on night shift? We don't know what the ratios are. We don't know what the facility's practices are in allowing proper handover and detailed clinical information. We do hear that despite all the effort that has to be put into claiming your ACFI documentation, oftentimes, not universally, but oftentimes actual clinical and it probably goes to some of the thing that way too often the healthcare needs are just ignored as being a key component of aged care, but the clinical records can tend to be very poor, clinical documentation can tend to be very poor across too many aged care facilities.
Well, if the sort of data system was in place that Professor Parker was talking about this morning, that you were here when she was speaking about that, so the handover, if there could be a seamless electronic handover from hospital back to facility for someone like that, the risk of this would be significantly reduced, wouldn't it?
Indeed. So there's the two things that she was talking about. One is the way that she was talking about Oregon specifically, but she was also talking about in the US, because once you're over 65 and in a nursing home, you attract the US style version of Medicare funding. The reporting is pretty strict, and so these things do get picked up. The other thing is that the My Health record, of course, was 31st of January, I think, was our timeline to opt out. So that's going to take time to build. And while there were the privacy concerns that needed to be sorted out, one of the great benefits over time will be that we will be able to build clearer data sets. We'll be able to identify particular issues, pockets of issues, specific health and other concerns that can then be acted on.
I would want to move on to another topic, but before I do, can I tender ANM 0001 0001 787, Commissioners?
The ANMF Aged Care Survey dated July 2016 will be Exhibit 1-19.
I understand there's a new survey. The 2019 survey is about to...
Yeah, so we backed this survey up with a shorter one, specifically focusing on situation post the ACFI changes in 2017. We've just done some pilots, December 2018 and January in New South Wales and Victoria for the next national one that we have prepared and we will administer in the coming weeks.
All right. Now, I want to move on to another topic, and for this purpose, might this document be brought up? ANM 0001 0001 3151. You have that in front of you. It's the National Aged Care Staffing and Skills Mix Project Report of 2016. Now, just to set the scene, this was a report or a project that the Federation funded.
Mm-hmm.
It was research carried out by Flinders University and the University of South Australia.
Mm-hmm.
It's a peer-reviewed and published medical article, correct?
Indeed.
I understand this does not come under the political hat of the Federation. This is focused on the care side of things.
Yeah, we direct particular activities for specific purposes. But one of our big things is, one of the core purposes of the Federation is the advancement of our professions and in thereby advancing the careers of our members. And we have expanded more and more because that is the sort of basic tenet of healthcare, evidence-based healthcare. We've extended more and more into that territory.
Evidence-based?
Yep.
Is it fair to say that this is an evidence-based system for ascertaining how nursing homes should model their staff mix?
Yep. What we would say it is, so it's an evidence-based staffing methodology to ensure that all assessed care needs for each resident in the country can be met.
All right. With your assistance, I'd like to spend a bit of time teasing out the methodology of the study.
Mm-hmm.
And if we could go, please, to page 3157. The evidence that it's based on is data from a large cohort of South Australian aged care residents.
So this particular project comprises two key stages, each of which had their distinct steps, let's say. The significant thing with this particular, there's none other in the country. The other significant thing with this particular project is that it actually looked at how do you staff against care demand. We had previously looked at how staffing is done, and staffing is done in many aged care facilities just by fixed rostering, and what people do is that they benchmark against what the sort of hours of care are just as an industry benchmark, and that's purely about supply. That's about, well, what staff do you put in there? That adds up to this hours of care. That's the industry benchmark. It had nothing to do with web, and when you referenced the ACFI before, it's not about applying the staff to actually make sure you tick off all those needs. That's what this one does.
Yes, thank you for that. If we look on that page that's up on the screen, page 7 in the report, you'll see there that there are 3 methods involved in this process. The first involves establishing resident profiles, 6 resident profiles.
Yes.
Now, from my reading of the report, that would seem to have been done by taking a statistical cohort of South Australian residents,
Yes.
225 odd.
Yep.
Some unrepresentative members of that group were eliminated. You're left with 200 people.
That's right. Normal process. You remove the outliers.
Yes. And that was then used to distill 6 typical resident profiles.
Yes.
And the profiles were by reference to their characterisation or the way they'd be classified under the ACFI.
Yes.
All right. Well, let's just have a look at the profiles. Unless what did you want to add? I'm sorry.
I'm sorry. I'm talking too much. But no. You'll tell me if it's too much. But because what we did here is, yes, with the ACFI, but what we did is we took the care plans.
Yes.
The care plans of how you were getting.
That's
there,
what
weren't you?
we're going to now. And these care profiles they're not real people.
No, they're de-identified.
De-identified.
Of
Okay.
the actual care plans. The profiles are, a typical person that
Yes.
we've personalised.
And this has already been published and been in the public domain.
Absolutely,
Yes.
absolutely.
All right. If you go to page 47, please, that's 3197. We'll just go through the 6 resident profiles, and these go from least in need of care to most in need of care. So profile number 1 is a person who's named as Vula, but that is not her real name.
No, it's not.
Let's just clarify that. If you go over the page, there is a profile of her care needs. So she is someone who is alert, has some confusion. She's a dementia patient who has just come out of home care. She wanders at night. She has generally good nutrition. She drinks. There's no problem with her drinking. She showers with little assistance, and she walks without aids. So she's mobile. She's continent. Her skin is intact but fragile, and she has no history of falls. Someone like that is right at the bottom end of the amount of time needed for their care in a nursing home, correct?
Very much so.
If you go back the page, in preparing the profile, the researchers who established the profile took a view that her residential care hours per day, that's the RCHPD, was about 2.5 hours a day. All right. Now, you see under that, focus group moderation is 3.
Yes.
Let's explore that. After the profiles were established and these evidence-based figures were attributed to each resident based on their care, the profiles went to a focus group. And how many were in the focus group?
I'd have to look that up, but there were small focus groups
Around Australia?
around Australia, but with small amounts, like 10 roughly limited, more less participants in each focus group to validate. Now, what happened? Do you want to leap to that place? Because so associated with this is the list of what we're looking at is the interventions that are required, then what that means, and then who should do it. Now, what our study did was aimed to be conservative because we're looking to set the minimum requirements.
Just pausing there, I just wanted to explain that the 3 is a figure that the focus groups came up with after they had been through all of the profiles, correct?
Yes.
All right. Well, now we'll come back to the
Okay,
actual
sorry.
individual care plans for the particular participants. So going back over the page to 48, and we see the care provided across shifts for this particular category of resident. And you'll see that there in the middle of the page. So that's broken down. You say that there's a portion of the report that deals with how that should be allocated to nurses and personal care attendants.
What was examined was what's the minimum level of qualification, knowledge and skill required to give each of these interventions.
Yes.
So what can happen is that a registered nurse, of course, can do all of these because nursing care encompasses the whole lot. So personal care is the more what we would call basic nursing care, essential nursing care sort of component. So in terms of us trying to come up with a methodology that would set the minimum staffing required, that's why we took that approach.
All right. So in looking at someone in that category, it would appear, based on the table at page 49, box 3.1, that there were interventions that would ordinarily be missed from someone in her position in the event that a nursing home was under stress, or that staff were unavailable, or that a casual came in, or, for example, that there were only personal care attendants on duty at a particular time. And these typical missed interventions are set out in box 3.1. You see those there?
Yeah.
So, for example, this lady being an early stage dementia patient, the first dot point is managing sundowning. Sundowning would appear to be calming them down when there's a sense of aggravation or
agitation.
Yeah. Okay. And the second dot point is on the same basis, that is redirection, reorienting the resident when they're confused. All right. Well, if we could move then to the second profile, and this is of the lady called Gwen. She's at the next level up. So in the case of this lady, it was ascertained that at least 3 hours
I'm sorry to interrupt, but I've just been advised that the video stream isn't working to the outside vision areas, so we will adjourn briefly and resume the moment the problem is corrected. I'm told the problem has been rectified. Yes, Mr. Bowles.
Thank you, Commissioner. I think we'll go back and start off with the resident profile 2 from the beginning. Ms Butler, this is the next step up in severity. The evidence-based calculation for this lady was 3 hours of residential care per day. The focus group moderated that up to 3.5. Let's have a look at some of the things that she needs. Firstly, she has asthma. She's alert. but she has a hearing problem. She needs some assistance with showering because of breathlessness associated with her asthma. She's got a mobility difference from the previous lady. She needs a frame for short distances. Continent most of the time. Her skin is intact and no history of falls. Again, we're at the bottom edge end of the spectrum for ACFI funding purposes. But she also needs some analgesia, that's pain management every day. Going over the page to the box at 3.2, the interventions that were often found to be missing in someone like her really picks up one of the themes of Professor Parker this morning. That is that she has a depressive illness that leads to sleeplessness and anxiety, and as you can imagine, that might involve extra care from a nurse. Why would that be from a nurse and not a personal care attendant?
It's just you're going to require it's better if you can have deeper understanding of what depression means and the measures we've heard the talk about, is particularly the non-pharmacological measures that you can implement to deal with the issues arising.
Yeah. All right. Let's move to profile 3. This is George. The next level up again. 3.5 hours of care time that was moderated up to 4. So he's 84. He's previously had a stroke and he's been through rehabilitation. So he's got mobility issues, and he would have a weakness in his left leg. So the issues would seem to arise because of his previous medical history. We don't have a dementia issue or a depression issue, but there would be physical problems here associated with delivering him his care. And if we go over the page, you'll see that's borne out in the assessment at the top of page 54. You agree with that?
Mm-hmm.
And the box 3.3, which identifies the sorts of things that might ordinarily be missed in the event that he was not being provided with person-centred care, are listed there. I don't think we'll dwell on them for now.
Can I just say one thing?
If you could, yes.
The supervision, that is a very significant problem. The supervision of fluids to prevent choking. That gets missed is a very significant problem, and there's research being done to show that that is causing significant issues in the sector at the moment.
All right. Would you be able to provide the Commission with details of the research on that particular topic? Because it's not something I'd heard of.
Yep.
Could you explain that a bit more, please, if you could?
Right,
Yes.
Yeah, most definitely. So you may be aware that Professor Joseph Ibrahim has done some research, and what he did was look at 13 years of coroner's reports of incidents that had occurred in aged care. He found that over that time there had been a 400% increase in preventable deaths, and by extrapolation, preventable situations. Falls was the greatest, but choking was in the top 4. So it's a very significant situation, and so linked to what we're talking about, when what gets allocated as the task for people to do is just set the meal down, maybe position the patient, and off you go to the next one. Not there, the person that would, with any of the right skills, is not there to make sure that you've got to check that the right diet gets provided. You've got to check, because it says soft diet here, but there are thickened fluids so that people who have these problems don't choke. And then you've got to assist and supervise.
All right. If we could move on to page 56 and the 4th profile. the gentleman with the name of Walter. The evidence-based figure for care was 4 hours, moderated up to 4.5 hours. We have an 82-year-old with dementia who has behaviour, falls, incontinence and wandering. So immediately you can see why he is someone who needs quite a bit more care than someone else. Now, could you expand upon the way in which the assessment has been characterised in his case over on page 57? Do you have that there?
So that it's characterised in the same way. It's just that he has more complexity across his domains, requiring more interventions and more high-level skills.
All right, and if you go down to the care provided across shifts, you can pretty quickly get an idea of all of the tasks that apply to caring for Walter. Correct?
Yes.
All right. The same goes for each of these profiles.
Yeah.
But is 4 hours a day enough? That's the question I ask myself. One would expect you would need a fairly skilled team of a nurse and a personal care attendant to deal with all of those things for that person in a day.
Well, as I was starting to say earlier, this is what the evidence suggests. So our evidence, which is collected, it's been through a series of evaluations to check that we have our evidence correct. And even though each group did moderate, the moderation goes up by 30 minutes, that's across all profiles. There's reasons for them wanting to do that. And when they were asked to assess, because what was the timings associated with these came from a tool that had been developed here in South Australia with the assistance of SA Health. It itself went through a rigorous process in order to know how we would construct those timings. So when the focus groups looked at these profiles and assessed the needs and then looked at who's doing them and how long it takes, at first they weren't shown the timings, so that they didn't have any influence. We actually consider that overall, statistically, we're not too far off the mark. I mean, we published this at the end of 2016. You know, it's could be arguable that we do need to review it, you know, and need to review it ongoing.
Well,
of course.
Let's go back a step. There's no other analysis of this kind in the space in this country.
None.
And no one's saying that this is the only model or that's cast in stone as if it were the Ten Commandments. You're not saying that.
Not at all. We're saying that in the absence of anything else, this is an evidence-based staffing methodology which would allow facilities to staff appropriately to ensure all care needs are met.
All right.
But you know, people might want to go and provide other evidence.
All right. And finally, the last profile, the second last profile is for patient Sarah. It goes up another half an hour. The evidence-based approach was 4.5 hours. The focus group moderation went up to 5 hours. And Sarah is an 82-year-old widow, and she has had a fall. She's not able to bear her own weight. She has a 10-year history of dementia. So we see the coming together of the physical problem with the dementia presenting a compounded issue for assessment, treatment and continuous care.
Yeah.
All right. And on page 60 we see the assessment by reference to the same categories that we've been looking at, and very similar process. In terms of what she needs, in terms of care. That's in the table in the middle of page 60. She needs assistance to shower. Obviously, dental is an issue. She needs to be transferred with a lifting machine, etc., etc. The interventions that are missed in her case, if you have a look at box 3.5, would you like to expand upon those on page 61? Do you have that?
Yep. Oh, yeah. So these are the sorts of things that are often missed. And I don't know whether you want me to talk about it here or when we talk about the missed care survey, but it goes to the heart of many of the things that people have to just don't get the time to actually do. Yeah. And so what happens is that there's particularly nurses, and it's not unique to high pressure situations in the aged care sector, but they will ration. They will ration care, and so they will pay attention to the absolute must-dos. So many of these other things that are significant and important end up getting missed. What could I just add that in terms of you look at, it is important to recognise that what we're suggesting is a minimum. So some of the profiles we're now looking at are very complex. There would be occasions where in a perfect world we would want to increase those hours on particular days in particular circumstances as an event happens, and that's where clinical and professional judgment is so important.
Can we move to the last profile? So this is, in the case of Norma, end-stage palliative care. Sadly, people don't remain in this stage for very long, but the complexities are even more pressing. So we have a metastasised breast cancer with a condition that is sharply deteriorating over time for an 85-year-old woman who is obviously in some considerable difficulty. The fact that she's had mastectomies, chemotherapy and radiotherapy would mean she would come into the facility in a very difficult state to start with, let alone the other problems that she has. So the sorts of care that are required here, you would imagine would be quite intense. The evidence-based hours allowed for someone in her position was 5. The moderated group after the focus group came up with 6. So 6 hours a day, that's a quarter of the day for someone in such a difficult situation. It would seem to be warranted. The care tasks missing, I think, is worth focusing on in the case of this particular profile. And that's at page 64. That first dot point, I expect would be a very difficult situation to deal with, because this is where we're at the pointy end and the end is close for this particular resident, and the family would be there, and that would take up some time dealing with all of that and the stress associated with that. What do you have to say about that?
So, and you heard from Professor Parker as well, like that there are some things being done to try and address palliative care in the aged care sector, but palliative care currently being delivered in the aged care sector is so different from palliative care being delivered in
a hospital.
Palliative care units and hospices, where they'd all be nurses as well, because we're starting to look at some very high level skills and things that are required here in the assessment. But once again, and it's the same, and the goal here is for this person to have the most comfortable and dignified death that they can, and for their family to be in the most supported environment they can. And in aged care, we're not doing that as well as we need to. And again, it's, as I was saying before, that rationing process. They will go to what must you can, of course, you would argue that this is a must-do, but they will go to the high care health must-do needs, and other things just get missed.
Yeah. There's nothing unreasonable about repositioning Norma every 2 hours to make sure that she's comfortable at this stage, is there?
Not at all.
The management of the medication would be complex.
Yeah. It'll involve the DDAs talking about drugs of dependence and
Yeah.
addiction, yeah. So, you know, morphine, etc.
And if Norma was in the hospital, if she was in acute care in the same situation, there wouldn't be personal care attendants looking after, would there?
It would be no. So the situation is a little variable across the country because there are some, I think we talked earlier about some undergraduate students of nursing, but there wouldn't be the PCW as we think of them in the aged care
Palliative
sector.
care in the hospital for someone like this would be just nurses
Yes.
and doctors.
Oh, indeed. And you know, others.
All right, now, after you created the profiles, worked them up, had the focus groups, the results went out to a survey of some 3,000 people.
Yep.
What was the result of the survey? We are now at pages 66 and following.
So this was the first time we had a baseline of, well, what should the actual care be?
Yeah.
You know, here are the series of interventions, nursing and personal care interventions that should be happening. Are they actually happening? So the Miscare survey is a tool that has been used, you know, in other places across the world, and so we customised it to this environment, and what we found were there were significant gaps in the care being delivered across everywhere, across the country, across, it did differ, but across not-for-profits, for-profits. What we did find that most often they said it was because of lack of staff. We found that only 8.2% of those participants said that they always had adequate staffing.
We'll come to that in a minute.
Okay.
If we could go to pages 82 and 83, and if we could look at those two pages together, the survey, and it commences right over on the left side at the foot of, at 5.7. The survey yielded some responses about why care is missed. This is the qualitative survey you were just talking about. Yeah. And I don't want to go through all of them in detail. They really all speak for themselves. But I just want to look at on page 83 at the foot of the left-hand side, there's a statement, lack of realistic goals from management. Somehow the residents who need the most care do not attract sufficient funding to allow for the extra staffing that they need. Yet the management and the families seem to think that those residents should be getting one-on-one care for their waking hours, or even 24/7. And this quite simply is impossible. What do you say about that?
Well, of course, one-on-one care in any sector is unusual. It does happen very occasionally in public sector. We call it specialing, for a whole range of different reasons, where a nurse will be with the particular patient all the time. But that's not typical. So even the most, if we use an hours of care model, even the highest hours of care we use in the public sector are 6 hours. Yeah. 6.5 in some, so that's normal. That's the normal nursing hours across a 24-hour period. Now, our study here used ACFI as the basis because it's the thing that exists. It's the only tool that exists in terms of identifying what the care domains are. It didn't go to any commentary about how they were funded, but just because we use that as the basis doesn't mean that we think ACFI is the most appropriate funding tool, because there's some merit in that comment, in that ACFI doesn't quantify how you provide that emotional and social care necessarily. It doesn't. The people with, you know, very low needs might attract $0. There isn't an incentive in that instrument to keep people well. There's an incentive to make them sicker in terms of getting a return.
Finally, on this topic of the survey, if we go to page 84 and the conclusion, there's a passage there that I did want to take you to. About halfway down that paragraph headed conclusion, it says the primary reason for missed care. Do you see that?
Yep.
Was identified as a lack of staff, increased resident acuity, which we heard about today, the skills mix with unbalanced resident allocations also being implicated. Workload, staffing and skills mix issues were also evident in the qualitative responses to the survey, as was a perception that the management of aged care was out of touch with the realities of care delivery. The missed care survey was undertaken to establish that under the current staffing complement, care is not being performed. All right, that's the second stage of the process completed. The final stage of a process of validation was what's called a Delphi survey. That's where the results were put forward to experts in the field who were identified as being, correct me if I'm wrong, a range of managers of residential care facilities. So it's the people who are responsible for implementing and setting up staffing profiles in their institutions.
We believed that to be important,
Yeah.
because the rest of it had been from people who are delivering care on the floor, and these are the people who are running the facilities.
So you have focus groups based on nurses.
Yep. And carers.
You
yep.
have survey, 3,000
Yeah.
people based
Yeah.
on,
Those working in the sector, across
in
the
the sector.
country. Yep.
and then the final Delphi survey goes out to the managers of these facilities.
Yeah.
All right.
Experts.
Now, the survey results of that commence at page 90, and if we just might focus on their responses to the questions they were asked. They were asked a number of questions, and they really do speak for themselves, but I just want to focus on a few. Page 90, the first one, 98% agreed that resident care needs have increased in volume and complexity over time and continue to increase. 5.2, 83% agreed that a person with complex care needs who comes to live in residential aged care is now living a much shorter time given the complexity of their care needs. 99% agreed that residents require more frequent and complex assessments to be undertaken by the staff. So that's one task that definitely needs to happen more often. There definitely needs to be more assessment. Mm-hmm. The poor gentleman, his situation would not have happened if there was a greater...
Indisputably.
In 5.4, you see that the percentage of experts who agree residents require more frequent and complex interventions and interactions to be implemented to meet their assessed needs, and it goes on. All of them speak for themselves. But if I could then go to page 93, where they were asked about the staffing methodology, because I think that's the critical thing for present purposes. 94% agreed a staffing methodology is needed to be built around assessing and meeting the assessed needs of residents for morning, afternoon and night shifts. So you've got to do it by reference to the care on each shift.
Yes.
And as we saw in the profiles, that's precisely the way in which
done.
it was approached. 5.12, the percentage of experts who agree a staffing methodology must include the building block of identifying the lowest level in the skills mix of staff who can perform the assessed activities a resident requires. Well, that really speaks for itself. The percentage of experts who agree a staffing methodology must include the building blocks of identifying the time and frequency of interventions. I could go on and go through them all, but they all point in the same direction. What do you want to say about this survey process and the results that it achieved?
So this is a technique that is just generally used as part of research, the Delphi method, where you typically have a group of experts to assess whether your findings are correct or incorrect. You're probably aware of it. We had 102 experts and specifically went to managers so that we're getting that particular view. This part of the process was overseen by the University of South Australia, and they were actually astonished how quick, because what you do is aim to reach consensus. They were astonished how quickly consensus was reached. And, you can see so you've got to send part of a Delphi is setting a benchmark. It's got to be high, like it's not like a 50%. 80% is considered to be an appropriate consensus point for validating your evidence. If you had 80% of the experts consistently agree, you can see how dramatic, how it's not just 80. It's it's close to 100 at times. So for that, it showed us that the steps previously, the methodology that we were putting forward was right on the money.
All right. Now, I would like to go back to the key findings of the study. If you go to page 99. And you see there the 4 key findings. Well, one is fairly obvious, given the discussion
What
we
we've
had.
talked about.
2, there doesn't seem to be any science at all in the current skill mix. Are you aware of literature about that, about practices? Is there any uniformity? Is there any standard about allocating staff mix?
No, what I referenced before about the benchmarking comes from a person who's an organisation that's reporting on financial performance. This is where the benchmark is coming from, and it's purely about what you're supplying. What we think our research clearly indicates that is there's just a gaping hole in the Aged Care Act currently in terms of how you actually staff against genuine care needs in residential aged care.
Right. The 3rd key finding, an evidence-based staffing methodology is needed, and that the principles underpinning the methodology tested in this study are appropriate for residential aged care. Now, the formula that's been worked out, you'll find at page 105, on the top on the right. So this is going to vary, obviously, from institution to institution. The more category
right.
6...
That's right. We tried to take account of, you'll see it says direct nursing and indirect nursing. So there are things that are like a personal care worker might do, like stocking equipment to do with the patient, but so it takes account of that. But there are other factors that are important out there, and a lot to go to a lot of why there's a lot of miscare. Geographic circumstances, layouts, several floors, several buildings, all of those sorts of things. But basically this is, you add it up and you get the number of hours. So what we've tried to develop, and we're now in the process of developing, is a calculator tool. We use them in the public system where a facility could go and say, well, I've got 90 residents. I know I've got X type number 1 profile, etc., etc. You input that and it delivers you the stuff at the end. It is a work in progress at the moment. Yeah.
Well, it would seem that if there's a method for determining funding based on the care requirements of each individual person, it's not beyond the wit of man to develop a system, a formula, a tool, a spreadsheet, a computer program, even an iPhone app
That's right.
that could calculate what staff must be at the facility as a minimum on any given occasion.
I would say it's completely within our realm to be able to produce it.
All right. And
Can I ask a question while you draw breath? In the work that's been done, and it's very impressive work, and I'm sure there's similar work in the hospital system. In the hospital system, we have acute care needs. What you're talking about for the most part is clinical care needs. Given that a person who enters residential care is there for a considerable period of time, that brings with it a requirement around personal engagement and so on. Do your considerations take any account of that in framing where you go with the clinical staffing requirements, or do you put those in the other 2 proportions of the ACFI?
They should be integrated, most definitely. What we have, and you're completely correct, one of the things that we have seen is that, and you've heard it talked about the increasing acuity, so we're seeing this drift towards residential aged care facilities now being more subacute facilities, and even though that's long-term care. One of the things is, and we mention it several times throughout the text of the study, is that rehabilitative, that didn't say that properly, and restorative care it just doesn't exist. So obviously we would want that to be built in. And what we've heard as well is about, it's not just the nurses and the carers. We need a range of people being able to contribute to our elderly people living well. So we see if we could get this staffing properly mandated, we see that as a core plank of improving quality safety. It's not the only one, but we do see that you're not going to achieve it without it.
just to wrap up on this report, if we go back to page 9, a conclusion is reached in the box at the top of page 9 in point 3. It says that there should be an average of 4.3 hours per day. That's 4 hours and 18 minutes, if you look at it that way. With a skills mix of nurse 30%, enrolled nurse 20%, and personal care worker 50%. That is a minimum.
Yep.
That's a minimum.
That's an average.
Yeah.
So that's an average, and because when we've just examined that we go from 2.5 to 5, and yet the average is sitting up at 4.3. That's to do with the distribution of the current population. It's much more heavily weighted to the high care end.
Yeah. Can I suggest this to you? That may need to be, and this is where there's some subtlety in the system. If you are in a high dependency home where most of the residents are levels 5 and 6 on your schedule, it may need to be more. The minimum may need to go up. The average, though, for a typical home, which has representatives of each of the cohorts, of each of the examples, because we've got to remember that the starting point here is that these examples are driven from a batch of 200 South Australians whose conditions, whose needs have all been statistically brought together into these 6 profiles.
Yeah.
In other places, there may be more high care on a particular facility.
It's going to vary by facility, and you will see that some providers certainly operate much more in the high care than the other end of the market, depending on when they are, who they are, all those sorts of things. It is not at all to deny when we think realistically that our first profile of VULA, the 2.5, we might not be seeing them in residential aged care much anymore because of the way the home care packages are working or not working. That policy is driving a situation. We completely support trying to maintain people well at home, absolutely, but it is driving a situation by the time people get to residential aged care, they're in a much more frail, complex, vulnerable state.
In the time we have left, I wanted to turn to another document.
Yes.
But might I, at this stage, tender Commissioners the National Aged Care Staffing and Skills Mix Project Report 2016, which is ANM 0001 3151.
The National Aged Care Staffing and Skills Report dated 2016 will be Exhibit 1-20.
Might we see the following document? ANM 0001 3308. Now, Ms Butler, you didn't stop with that document. You went and got Flinders University to carry out a financial cost-benefit analysis of the recommendations. That is, what it would cost the budget, what the implications would be in terms of benefits, intangible benefits, etc. I just very briefly wanted to take you to the conclusions of that report, because obviously you'd appreciate that funding for such a staff skills mix would involve increases in funding at some level.
Yes.
Look, if we could go then to the end of that report at page 20, which is 3335. If you could perhaps take us through the results that you got from Flinders Uni when you asked them to cost this.
Yeah. So obviously we anticipated that the first question would be, oh, well, how much does it cost? We don't have the money. So we wanted to conduct a proper cost-benefit analysis because we already knew that there's a lot of cost shifting happening because of all the things we've talked about, the transfers to hospital, etc. We're obviously not economists, so we went to economists and got them to do the modelling for us. So now this is based on 2016 figures and the identified 2016 demand. There's a National Institute of Labour Studies puts out an aged care survey report periodically. So that founded in terms of numbers and what the needs would. So you heard earlier that there's only about 14% registered nurses in the sector. So in terms of working out, well, what's it going to cost? How many do we need, etc., etc. So, and we did two parts. We did just and this is full implementation of the recommendations of the report. What's it like just as a baseline, and what's it like adding a 10% wage increase?
If you go over to page 22 and 23, if we could have those two side by side, you'll see the two longitudinal analyses that were carried out.
So what the study, what this concludes is that it would say, and it claims that it's made conservative estimates because parameters haven't been tested, etc. It's cost benefit neutral. While it will cost $5.3 billion to fully implement the increased staffing and skills mix requirements, that will, and it also factors in the additional support costs that will be required. That is offset by a number of different features. So one of them is that includes the increased tax take when you increase that sort of thing. Then that's also a significant component is what you offset by hospital avoidance, all of those sorts of complications and requiring any other medical health professional assistance, etc.
Can we just go through the offsets one by one? You've got an offset there of savings re staff attrition.
Oh, sorry, yes.
What does that mean? If you spent a little bit more to make the care better, you might lose fewer staff.
It will indeed, because you know what, if you had proper staffing in the places, people would feel satisfied, fulfilled in their jobs as nurses and carers, and we wouldn't see the churn that we currently see. We identified it as about 500 million. John Pellaire's report, he identified it exactly the same thing as 488 million. So we're pretty much on the money there. So that's a significant offset. Then the other ones are it's such tiny writing.
Cost shift to productivity factor. What's that?
That's about not having to the cost shifting is sending the care elsewhere all the time, but if you have the right staff, you can do the things where you need to do them because you've got the right people and you've got enough of them to be able to delivering the right care. So then obviously the hospitalisation, the hospitalisation costs and the tax take. Then they used a specific modelling that I won't attempt to, it's an economic model, to quantify these intangible benefits. Now, reduced mortality, quality of patient life and quality of relatives' experience. Reduced mortality, now this might sound a little harsh, but if you keep somebody alive for longer and living well in the residential aged care facility, you actually save money because resident churn, to describe it in a horrible way, actually costs money. So the other thing is the quality of patient life, what it actually would add up to by keeping someone happy and not socially isolated, engaged, living with dignity, etc. What's not covered here but should be recognised, and this is the part that we always ignore. We just always ignore that. But what research now internationally is starting to explore, it's starting to explore the impact of the quality of patient life on improving health outcomes. So you start to get a bit of a sort of snowball effect where if you keep that well, you also keep their health well, you keep them, it just keeps compounding to deliver benefits.
Yeah. All right. I tender that document, Commissioner. It is, go back to the number, ANM 0001-0001-3308. It's the financial and cost benefit implications of the recommendations of the National Aged Care Staffing and Skills Mix final report by the Australian Industrial Transformation Unit of Flinders University.
The Flinders University report on the costing of the recommendations made in Exhibit 1-20, dated May 2017, will be Exhibit 1-21.
It's one more question, one more very small topic I wanted to raise. Could the transcript of yesterday at page 89 be brought up on the screen? From the 11th, sorry, the 11th of February. Yes, the 11th of February, please. Can you see that there? I believe you were shown a copy of this before you gave evidence today.
Yep.
This was some comments that Mr. Yates made about the role of nurses in service delivery in residential aged care facilities. And can I draw your attention to, firstly, the question that he was asked. It was about ratios, how ratios have changed between qualified and enrolled nursing staff and the other personal care staff in recent years. And Mr. Yates was asked what was driving that and did he think it was appropriate. He says, and this is the question, this is the comment that I'd like your response to. He says at line 19, I mean, is everything that a nurse used to do have to be done by a nurse? sometimes, in fact, and I'm going to get into trouble about this, I think he was right there, but sometimes the strong command culture of nursing historically, and I recognise that that's also been addressed, has meant that in terms of things like consumer-directed care, consumer-centric practice, that there has been more resistance from nurses and nurse administrators, and that then there have been then there have been to others whose experience might be, for example, in the hospitality industry. What's your reaction to that?
It's not the first time we've had this particular, it's not an altercation at this point, but we have had a discussion previously around comments of this nature. What's unfortunate, I think, with this is I'd like to know what evidence that comment is based on in the very first instance. To me, it seems solely opinion. There is a confusion for someone, and he's not in the position to understand what nursing is, what nursing care is. As I've just said, nursing care encompasses the whole of the sorts of things that we're talking about. Clearly from our study, we are saying that 50% of the time, we believe a personal care worker can perform many of the care interventions that are required in the sector. But what we're saying is that for the best care to be delivered, we need the skills mix that's been identified by evidence of 30%, 20% and 50%, ideally, and 50%. I'm not exactly sure about what he's saying about the strong command culture. I mean, we're talking about World War II. I'm not exactly sure what that comment is meant to mean.
All right.
But it just demonstrates a significant lack of understanding of the nursing profession.
They are all the questions that I had, Commissioners.
Ms Butler, thank you very much for your evidence. It's very important that we have an insight into the way in which the principal caregivers in this industry are working, and the demands that are being placed on them and their capacity to meet those demands. Your evidence has been most helpful. Thank you. The Commission will adjourn until 10 a.m. on the 18th of